rings. So when you have a very young patient, a child or teenager with keratoconus, you usually tend to implant earlier, because the earlier the manifestation of the disease, the more aggressive. The same is patients with the eye rubbers. They tend to progress fast. Availability of frequent visits. I know that sometimes you may treat patients from neighbor countries, and maybe difficult to see these patients regularly. So in those cases, you can implant earlier. Keratoconus stage, you should avoid to implant in very advanced keratoconus, because sometimes the best time for implantation has passed. And keratoconus in the family, genetic cases are usually more aggressive. So if there are relatives with keratoconus, we tend to implant earlier. So I'll show some cases, some very practical cases. For example, this is a lady, 70-year-old, keratoconus diagnosed 30 years back. She's happy with contact lenses. There is no reason to implant rings here. The patient is happy, and there will be no progression. In this case, a 12-year-old boy with a severe allergy. We treat the allergy before, and then implant the segments. You can see here a very good improvement in terms of corneal regularity, in terms of visual acuity gain, and also a reduction of astigmatism. This is a case 3, a 57-year-old man, keratoconus grade 2. The patient was well, but he would like to improve a little bit if possible. So if a single segment, we could improve one line of vision, reduce the refraction, and the patient is very satisfied with the result. This is a boy, 11-year-old, without progression, keratoconus grade 1 to 2, but with good visual acuity. We just follow this patient. A 15-year-old with documented progression of keratoconus, a very good pre-op visual acuity. I know some would indicate cross-linking in this case, but I personally prefer to go first with rings, and the final visual acuity is 20/20, and the patient is very happy. Another case, a 12-year-old boy, progression of keratoconus with a long arc segment of 300 arc length. There is improvement of visual acuity, a great improvement in refraction, so a very good result. Another one, a 19-year-old boy here, advanced keratoconus with Volt's trial, and a very good result with 20/25 final result with 2 segments. And in more advanced keratoconus, you tend to implant the long arc segments, as this one you can see here, the 320 arc length with good visual acuity improvement and good flattening effect. Another one, advanced keratoconus with a vinyl visual acuity of 20/30. And about these long arc segments I just mentioned, you could implant it with a manual technique or laser, but ideally you should always implant it with the laser, because to implant it with the manual technique you should use this spatula in a spiral, and the problem with this spatula is the risk of perforation, because as you may expect, the tunnel depth proximal to the incision is different from the tunnel depth distal because of this spiral spatula. So the risk of perforation during the tunnelization or even during the ring implantation, as you may see in this case. The tunnel was manually done, and you can see here the Sinski hook, and after you can see some aqueous leaking from the incision, as you may see. Look. So there was a perforation. And what to do in this case? I remove the segment. As the perforation is very distal, I implant another segment with a 210 arc length that will not go up to the perforation point, and you undercorrect, because the ideal would be the 320, but even with the 210 you can get a very good result. And this association of 320 arc length with scleral lens is a fantastic association. You can get 20/25, 20/20 vision, even in advanced keratoconus. So you use it very often. In these long arc segments should be used only in central keratoconus cases with hyperprolate corneas, moderate astigmatism, and visual acuity worse than 20/40. It works as a new limbus because the flattening effect is the same in all around in all area inner to this segment. We published a paper some years ago about the effects of this relatively new ring. Today is not a ring, not new anymore. And as you can see here, in more advanced keratoconus with more than 60 diopters, there is on average 8 diopters of flattening. This is a huge flattening effect and very effective. Another important point to consider is the association of cataract and keratoconus. It's quite, it's relatively uncommon, but becoming more and more uncommon with the increasing incidence of keratoconus. There is no consensus regarding IOL calculation after rings, and you should always implant after keratoconus stability. It's a prerequisite for cataract surgery. So as a rule, you should always treat the keratoconus first with the rings, if the cornea is very aberrated, very deformed, before cataract surgery, and just proceed to cataract surgery at least 3 to 6 months after the ring implantation. As you can see here on this tomography, there is cataract and a thinning of the cornea, of keratoconus. So in those cases, usually you have a steep cornea with high astigmatism, so it's difficult to get a reliable keratometry. And typically there is an overestimation of keratometry and a tendency to postoperative hyperopia. So you should always aim for some myopia post-op to avoid this post-op hyperopia. As I told, there is no consensus about the formula selection. In most cases, you should use a multi-formula approach, never rely on a single formula. So I personally use SRKT, Barrett, and Kane, and evaluate the results of all of them, and try always to have a target of at least -1 to avoid this hyperopia. We should always implant monofocal in those eyes. Torics are off-label, but in some selected cases you could implant, but you should not implant in patients with high risk of future keratoplasty, or in patients that will use RGP contact lens after cataract surgery. So when could you use the toric IOL in those cases? When the astigmatism is not that irregular, so when the keratometry and meridians are relatively reproducible in different devices. And in those cases you can use toric IOLs, especially if the patient is not too young with risk of progression. And this is a very beautiful case. A ring was implanted many years ago, about 10-15 years ago. And after that, the patient developed cataract, and you can see the toric marks very in the steepest axis where the ring was implanted. This is another interesting case of association of cataract and pellucid marginal degeneration. This is a very advanced cataract, PSC, and the astigmatism on the left eye was 15 diopters, a very advanced keratoconus, advanced PMD, and one segment was implanted. The astigmatism reduced from 15 to 8.7, and in a second surgical session, the second segment was implanted and reduced even more to 5.6. And then the cataract surgery was performed with a toric IOL implantation, and the final visual acuity was very good with a minimal residual astigmatism of 1.5, and the patient is very happy. But when you have an unexpected result, what you have to check? There is an ABCD of the unexpected result that states for A, asymmetry, B, biomechanics, C, centralization, and D, depth. So the asymmetry can be the cornea itself. It's related to the ring selection. And the asymmetry can be of the implanted segments. It's related with surgical technique, a not proper surgical technique. It's quite common for us to see this V pattern of asymmetry in keratoconus. Usually the ectasia is temporal in both eyes with this V pattern. And in very asymmetrical cases, as this one, we should implant rings in an asymmetrical way. I mean, more segment in the steeper areas and less or thinner segments in the flat areas. In this case, for example, it was implanted long arc segment, and there was a huge flattening effect in an area that was already flat, and this induced aberrations, and the vision was not as good as could be with a single segment, for example. Another case of asymmetric keratoconus with a 320 arc length segment with asymmetry, post-operative asymmetry, leading to a suboptimal result. Here you can see asymmetry of segments. This is related to the surgical technique. This is seen with the manual technique. In some cases you can have even a good result despite of that, but it should be avoided always, obviously. The B states from biomechanics. It's related to the corneal rigidity, and the cornea can be too stiff or too soft. It needs to be better understood. There is no integration of biomechanics with nomograms. Maybe it will be the next step of improvement of nomograms. The C states for centralization. The cornea should always be coaxial to microscope. So remember to ask the patient to have the chin up during the surgery. A proper marking of light reflex of the cornea. You need to remember that our point of reference for centralization is not the pupil, but the light reflex on the cornea. And when using the femtosecond laser, you can change the tunnel location if needed to get it centralized. So here you can see the patient. The chin is down. I'm putting the chin up to have it very coaxial to the microscope. This is important to get a very centralized segment. And here's the manual technique, an edited surgery, but you mark the cornea, and then you set the diamond knife at 80% of pachymetry at the incision site, and look at the exposed blade to make sure in a proper depth, and make your incision perpendicular to the corneal surface. After you make a tunnel, and then we pull up the roof of this tunnel with a Sinskey hook, and with a spatula you make quick and rotary movements with the thumb and indicator of both hands to make the tunnel. And after that, you take out the segment from the package, and remember that your tunnel is very deep, and just keep pushing the ring into the tunnel until the desired position. After pushing it up to some point, you switch hands. On the left hand, I use a Sinskey hook, and the right hand, the McPherson forceps to retrieve the Sinskey hook from the hole. And the ring is very well positioned in this way. With the femtosecond laser, it's much easier because you can move the position of your tunnel after the docking, after the vacuum. So the work here is have a properly positioned tunnel, and then open up the tunnel and implant the segment. So the learning curve is much less comparing with the manual technique. But after the learning curve, even with the manual technique, you can get very good results. So these are extreme wrongly positioned segments. The segments should not be implanted in those positions. And D is state for depth. So the ring could not be too superficial, could not be too deep, ideally, and not even the mid-stromal. Ideally, 75 to 8% depth of the cornea. It's the ideal. So here on the left side, you can see a segment at mid-stroma to superficial, and on the right side, the ideal position of the segment, about 100 micron endothelium. Here's a pre-deciment segment. It loses almost completely its effect because it's no longer an interstromal ring, it's a pre-deciment ring. And also, in this case, you can have some endothelial cells impairment. As you can see here, on the left side, the endothelial cell count and the aspect of the endothelial cell count, the cells, after a very deep implanted segment, and the other side, and the unoperated eye. You have studies shown that the ring is very safe for the endothelium, unless it's very deeply implanted, as you can see here. And here the opposite, a very superficial ring. It can impair the ocular surface, impair contact lens fitting, and increase the risk of postoperative extrusion. This segment should be removed and reimplanted. Another case of very superficial rings you should always avoid. To finish, to summarize, I'd like to share with you 10 pearls to successful ring implantation in keratoconus. What are the points you need to pay attention? So first, be careful in patient selection. Very mild or very advanced case can get good results, but very unsatisfactory results if you don't talk to the patient about what you can expect from the surgery. The best results absolutely are keratoconus grade 2, moderate to high astigmatism. So very mild case, you should in most cases just follow the patient. Very advanced case, this patient ideally would go for a dog, but in some cases you can go with a ring and telling the patient that probably he will need a dog in the future just to gain some time in some cases. 2, you should always evaluate the potential visual gain. Use the pinhole. The pinhole will measure the potential visual gain. It's important to have it. And if you have associated disease, as for example cataract and keratoconus, or high myopia and keratoconus, we should always treat the cornea first and then proceed to cataract surgery or phakic IOL. The third, you should always prepare the ocular surface for surgery. So treat dry eye, treat allergy. You should avoid operate the patient soon after removal of contact lens. If possible, I know that it's quite difficult for some patients to be without lens for example 15 days, but it would be the ideal. So this is a very dry eye patient with allergy. If you don't treat this before, there is a risk of corneal neovascularization after the ring implantation. So we should always treat first those conditions. This is a case of warpage. On the left side, you can see a patient wearing contact lenses, and on the right side, topography 15 days without contact lenses. There is a very different pattern of keratoconus. The fourth step, you should always plan the surgery according to the nomogram. There are several nomograms. I could not tell about nomogram on this presentation because of it would be a full presentation only about nomogram, but I use an asphericid-based nomogram, that is the Ferrari ring nomogram. But as you become more experienced, you can make your own adjustments to make your personal nomogram. And you should always respect the relationship between ring thickness and pachymetry at the ring track to avoid thick segments in thin corneas, because this is the main risk factor for ring extrusion. And this is the equation of the nomogram I use. The asphericity pre-op minus the asphericity induced by a given segment should be closed to the normal asphericity value, that is minus 0.23. In the Pachymetry's law, as I showed, to avoid thick segments in thin corneas, the surgical technique should be the best for the case, but also the best for the surgeon. For example, if the surgeon has no expertise with the manual technique, there is no way to proceed. You should train before, pass the learning curve to avoid complications. In real operations, you usually use the manual technique. The 6, intraoperative concentration, as I showed previously, it's very important to not consider the pupil center, but to consider the light reflex on the cornea. 7, we should always have additional segments and different segments available because they can fly from forceps. Sometimes you can lose segments because they are very thin, very delicate. And in case of intraoperative complications, you may change your original surgical plan, as I showed in that case of corneal perforation. So important to have some segments available. 8, the post-op. You should always treat the patient with artificial tears, anti-allergic, eye drops to avoid, and ask the patient to avoid rub their eyes. And it's very important to advise the patient about the visual fluctuation for 3 months after the surgery. In some days the vision will be good, in some days the vision will be bad. It's normal in the first 3 months after the surgery. And 9, correct the residual ametropia with glasses, contact lenses, phakic IOL. There is a new ring called hemimyopia ring. That is a 6 millimeters optical zone ring that we implant after the original segment to reduce myopia. And PRK is very controversial after ring segment implantation, but in some very selected cases you can go for a PRK. This is a scleral contact lens after ring with a very good result. And these are the options, phakic IOLs after rings. And then follow-up. You can make some refractive adjustments with glasses, contact lenses, or those different options. And you need to follow the patient to evaluate possible evolution. You should go to a cross-linking. May this patient need a dog in the future. We published the paper several years ago, and in which we follow the patients for 10 years after ring implantation. And we found that 80 to 85% of patients after ring implantation has the disease progress and stopped. So which one are those 15 to 20% of patients that keep evolving after the ring implantation? Very young patients, children, or patients with very advanced keratoconus, grade 4, because in those cases the best time for the surgery in this advanced case has passed, and in children because they are very aggressive. In conclusion, the rings keep evolving with time, and in the future we may expect nomograms assisted by artificial intelligence, biomechanics, integrated nomogram, new ring designs. And to have success outcomes, you should always be very careful on patient selection, ring selection, surgical technique, and post-operative care. Thank you.
Thank you very much. Пожалуйста, если вопросы, наверное, сразу сейчас. У кого какие вопросы? Questions?
I have a couple of questions. Yes.
Dr.
Lovely talk, Dr. Toketi. I have been doing, I think we come from a part where we use more of the intacs.
Yes.
Which is a slightly version where you put it about 6, and if you have the SK, you probably put it slightly closer. What our experience also is broadly 2 things. One is that for central cones, it works well. For eccentric cones, at least in our part of the world, which is more common, these may not be the ideal way to actually go ahead. It may be a part of the solution. So what we prefer is to, if we have thickness available, to actually do a surface ablation combined with mito, make it more regular, and then take a decision regarding rings. Scleral lens now has become very popular because of ease of availability. So our present approach is shifted because there is a range where both work well. The PRK, mitomycin, and the Intax, which is grade 2 to 3, which both give actually fairly good results if you combine it with the ring. So what is your experience? Do you prefer to lean towards rings, or do you prefer to lean towards laser?
Oh, yes.
В случаях, доктор Анн говорит, что в случаях, когда центральный кератоконус, он согласен с лектором, что действительно кольца сами помогают хорошо, но в случаях, когда очень тонкая роговица и не центральный кератоконус, он спрашивает, какой он путь, то есть какой он путь выбирает больше. То есть сами кольца не очень хорошо помогают, либо он использует ли он либо какой-то полусегмент в последующими кросслинкингом, или же использует склеральные кольца, или же имплантацию хрусталика и так далее. Что он предпочитает? То есть это как бы такой.
Well, as I showed, there is a relationship between the optical zone of the ring and the flattening effect. So I use, in most cases, I use a 5 mm optical zone. It will have a very significant corneal flattening effect, and Intex are available only in 6 and 7. So it's a different approach because I personally, I tend to avoid to remove tissue. I prefer always to add tissue because it's a weak cornea, even with cross-linking, PRK and cross-linking. But I think that a single segment at the area of steep cornea in a 5 mm optical zone, in most cases, the results are very good. So I think the key here is the optical zone. Yeah. About scleral lens, I always use after rings, unless the patient has a very stable keratoconus. A patient, for example, is 30, 35, 40 years old, because some patients wear the contact lenses, for example, young patients, and it can mask the keratoconus evolution. The patient is satisfied with vision because it's comfortable, the vision is good, and sometimes the patient stays a long time without coming for follow-up, and keratoconus can progress. So I view the scleral lens as a rehabilitation just after some treatment is done, unless the patient is very, very stable and the age is a little bit more.
Он предпочитает вот при таких случаях, сложных случаях, он не отдает предпочтение методам, которые истончают роговицу, типа ФРК или ласик. Вот при случае у пациента с кератоконусом он предпочитает что-то добавить, типа кросслинкинга. То есть он не сторонник того, чтобы убирать ткань. Наоборот, он сторонник того, чтобы добавлять. Если после полусегмента, то есть одного сегмента, пациент доволен сам, хотя он не видит 100%, он оставляет этого пациента все, и наблюдает. Если пациент чем-то недоволен, он пользуется склеральными линзами или, возможно, хрусталиками дополнительными. Ну, говорит, все зависит от степени удовлетворительности пациента. Пациент удовлетворен или нет. То есть он предпочитает что-то не удалять, не ФРК только. Ну, в редких случаях только ФРК.
Just a couple of comments and then a query. Now, we've got good results. We are shifting towards, at least in our part of the world, I come from India, where people are shifting towards stromal addition.
Yes.
Yes, where we are putting, let's say, a smile lenticule, or even something like the intracorneal rings made of corneal segments. Yes. And our early results suggest that it's not, you don't have a nomogram for that, unfortunately, but it's still early days, and I have been in touch with Dr. Susan, who used to push that a lot. I'm still skeptical, but stromal addition, I feel, is the way forward, partly because it's more biocompatible. Now, the second part is what I find is that there is no way of actually grading the keratoconus in the real sense, though that's what traditionally we've been taught. I prefer to split it as structure and function. So make the structure good, that is, you strengthen it with cross-linking, and then work on the function, or rings. Rings is also structure, and then work on function, which is vision, which could be glasses, intracorneal, scleral lens, or ICL. So that's how I kind of approach and explain. I find that when you tell grade to the patient, they get totally confused. So telling them in structure of how to build a house, you build the exterior and then go for the interior. I find that works.
Yes.
То есть он соглашается с доктором, что лучше что-то добавлять, либо лентикулу, либо кольца, либо что-то, чем удалять что-то из глаза. То есть он тоже, он согласен с мнением доктора.
I completely agree with your separating treatment and rehabilitation, because otherwise it's confused even for the patient. I completely agree. I tend to work in the same way. About the intrastomal collagen, the kinds, for example, that Susan has brilliantly described, I do think this is the way to go, because there is no extrusion. But the only problem is the collagen turnover, because the metalloproteinases enzymes are inside the stroma and they can reduce at the long term the effect. So these patients need to be followed at the long run to know the long-term effects.
And the last part was, in your part of the world, collagen cross-linking is not the first step, is from your understanding?
Yes. Do you want to translate?
Доктор делает первым этапом кросслинкинг, а вторым этапом только добавление тканей, или кольца и так далее. А доктор только предпочитает первым этапом сделать кольца или лентикулу, а вторым этапом делать кросслинкинг по необходимости.
To tell the truth, I have a very biased tendency, bias in the mean to believe what is best for the patient in terms of safety, improve visual acuity gain. So I tend to implant much more rings, and I use cross-linking alternatively. For example, there are some recent reports of oral riboflavin being useful. You do not know if it really works, but it seems to work. So in most cases, I do rings first and cross-linking very, very rarely.
Very rarely.
Yeah. I know it's a different approach.
Доктор еще раз подтверждает, что в его опыте лучше сначала делать операцию, то есть механическое воздействие на роговицу, в последующем уже лечить медикаментозно, типа кросслинкинга. И он еще добавил, что у него есть опыт, пока так нету публикаций, лечения пациентов с кератоконуса оральным применением перос рибофлавина и в последующем воздействием, естественно, ультрафиолетовых лучей от солнца. То есть у него реально есть эти опыты. В Бразилии солнце
Yeah. Here's the sun as well.
В Узбекистане тоже солнечно, говорит.
Доктор Такет, можно ли понять из вашего ответа, что острота зрения не всегда главный показатель после имплантации колец?
Do you consider that visual acuity is not main result? Main result is structurally.
No, both.
Оба.
It's important to improve the visual acuity and the structural function of the cornea as well. Both.
Он имел в виду, если можно каким-то образом без хирургического вмешательства добиться коррекции очками, он предпочитает назначать очки, чем вторая и третья, то есть хирургия. Если пациент этим доволен, то есть он говорит, все индивидуально, это зависит от уровня удовлетворенности пациента. Если пациент удовлетворен, то, что он в очках уже стал лучше видеть, то его лучше так оставлять.
Нет, просто иногда пациенты, да, по нашему опыту, получается так, что они думают, что после имплантации колец все, и он очки не должен надевать, ни линзы, поэтому я об этом и говорю, что не всегда зрение повышается, но лучше происходит коррекция.
Поэтому он сказал, в презентации сказал, что он самое главное перед операцией с пациентом беседовать и объяснить, что его ожидает от операции. He say about patient expectation. For example, our patient expect from operation 6 to 6 vision But after when he is trained, for example, 2010, he is not completely
Satisfied. Yeah, as I mentioned during the presentation, we need to address patient expectations, because this is not refractive surgery. You are aiming to improve the vision. In some cases, for example, the patient comes for the 1 month visit and tells, doctor, my vision is not good. And I tell him, well, there is a refraction to be corrected after 3 months. And I make the refraction and show the patient that it has improved in terms of lines of visual acuity gain, reduction of refraction. So, but you need to tell the patient that he has a disease. You are treating the disease. And the visual gain will come after 3 months after correction of the residual metropia.
Он отвечает, что перед операцией, то есть имплантацией колец или вот других таких операций, с пациентом надо беседовать и объяснить, что его ожидает. Что это операция не рефракционного характера, что это операция для устранения прогрессирования кератоконуса. И через 3 месяца минимум, а так через 6 месяцев ему можно пообещать рефракционную хирургию, либо ФРК, либо имплантация хрусталиков. То есть имплантация колец в первую очередь необходима для остановки прогрессирования кератоконуса. Он говорит так, самое важное, говорит он, пациенту объяснить, что его ожидает. Что его ожидает не 100% зрения, что болезнь кератоконус у него есть, будет и останется после операции. То есть если он хочет 100% зрения, в последующем, возможно, ему надо будет делать рефракционную хирургию, ФРК и так далее. И его пациент, он говорит, что аналогичный случай у него. Его ожидает, что приходит со зрением, почему я не 100% вижу. Он потом объясняет.
Еще у кого-то вопросы?
Thank you. Oh, yes.
Welcome to Uzbekistan.
Thank you.
Я хотел спросить, в связи с развитием, с внедрением имплантации интраэстромальных колец, является ли эта методика единственным правильным способом для хирургической коррекции центрального кератоконуса? Или же все-таки остается сегмент, где необходима все-таки сквозная кератопластика? Сквозная кератопластика. Вот его мнение, может быть, даже в процентном соотношении.
Ask about what indication only for ring implantation, and where is indication to start to do keratoplasty, dark or penetrating keratoplasty. In that cases, you prefer rings. In that cases, keratoplasty.
Well,
and his main question is rings useful in all cases of keratoconus, central keratoconus?
okay. There are 2 limitations for ring implantation in those advanced cases. First, the corneal thickness at the ring track. So, if you can implant at least at 200 micra, you can go with the ring to have some improvement.
Первое ограничение – это толщина роговицы. Если толще, чем 100, то есть если ты можешь сделать этот туннель толще, чем 100 микронов, вы можете имплантировать. Ограничение толщина.
And the second point is corneal opacity. If you have, for example, a central scar, so the result will not be good. So,
Второе ограничение – это помутнение, разное помутнение роговицы. Если вы имеете уже центральное помутнение, то уже это бесполезно.
because there are some very advanced keratoconus, for example, with a 65 diopters maximum, if a relatively not thick but not too thin corneal thickness at the ring track, so it allows us to implant segment. But you need to have a relation of 50% of the corneal thickness should be the corneal.
200.
For example, if I have a 400 micra thinnest point at the ring track, the maximal ring thickness I can implant is 200 micra. Should be half. So if I have a 400 micra, I cannot implant a 250 micra segment. because it's more than half. So this relationship should be in mind, otherwise you can have extrusion, because it's a thick ring in a thin cornea. So the main limitation would be the thickness at the ring track and the clarity of the visual axis. Otherwise, you can implant in every case.
Например, в случае, если кривизна роговицы даже 65, и толщина роговицы в том радиусе, где имплантируются кольца, в 2 раза толще, чем толщина самого сегмента. То есть, если он говорит сегмент 250, но минимум 400, то можно использовать. Но при условии, если центральная оптическая система прозрачна.
То есть мы можем сказать, что поздние стадии кератоконуса все-таки предпочтительно будет.
Вот он говорит про 4-я степень кератоконуса, но оптические среды прозрачные, то можно. То есть это, да.
Thank you. Thank you.
Спасибо. Это, я извиняюсь, не представил, кто вопрос задавает. Это мой ошибка по неопытности. Михалик Фрашан Артыкович первый вопрос задавал. Это доктор Анан Партасарати, наш коллега. Он вопрос задавал и транслирует, переводит доктор Улбек Карим. Спасибо. Еще у кого-то вопросы? Доктор Акмал Маткаримов.
Okay.
Во-первых, спасибо за хорошую информацию доктору. Вопрос в том, что вот если получилась перфорация роговицы, да, при имплантации интракорниальных сегментов, и невозможно, как вот вы показали, невозможно альтернативу как бы вставить. Когда через сколько можно взять пациента на реимплантацию?
If during operation, perforation, how long period, waiting period for second surgery if you don't available any in our responsible methods?
Okay. After perforation, the stroma collabates. There is a collapse of stroma, and there is a tiny scar at that point. You should wait at least 1 month, ideally 3 months. And if possible, try to avoid that area, especially with the femtosecond laser, because if there is a scar, the femtosecond laser will not cut properly that area. If you could make an adjustment to avoid that area, is better.
No bigger, no smaller, but in our segment, you mean?
It depends on the nomogram. If the nomogram tells you to pass through that area with a 5 mm optical zone, for example, and you have the option to choose a 6, you should go to a 6 to avoid that area. But after 3 months, if there is no way you have to go through that area, you can go. If the femtosecond laser, be prepared to have the spatula to make the tunnel only at that point, because it may not cut the scar.
Если такое случилось, у вас альтернативы нету, то ждать надо минимум месяц, а так оптимально 3 месяца. И через 3 месяца, если это было сделано с фемтосекундом, можно на том же месте делать, то есть второй туннель на том же месте этого. Или же там, если грубое помутнение после проникновения, то выбирать другой сегмент. То есть это подсказывает только номограмма, не доктор решает. То есть по номограмме, опять же делать через 3 месяца заново по номограмме. То есть идеальный месяц ожидания 3 месяца.
Спасибо большое. Еще у кого-то вопросы? Значит, у меня самого вопрос. Значит, какой диаметр колец предпочитает доктор Таркети имплантировать? И второй вопрос. Как насчет проблемы оптических феноменов? ГЛР, ГАЛО, все вот этих побочных.
До и после операции.
Да, после операции, да, имеется в виду. Многие пациенты жалуются просто. Самая большая проблема в этом.
Which size of rings you prefer? Second question, how do you decide problem with the post-operative aberrations?
Okay.
Yes,
Okay.
aberrations.
Okay.
Phenomena.
Well, in most cases, I implant a 5 mm optical zone because the flattening effect is bigger. Okay.
Он использует больше 5-миллиметровый размер, потому что у него эффект уплощения больше.
But there is a drawback. There is a problem with that. That is, there is a high incidence of halos and glare because of that.
Но есть проблема, если использовать маленькие кольца, то больше оптических эффектов.
But usually these effects tend to solve with time in most patients, and if it does not resolve with time, you prescribe diluted pilocarpine or brimonidine to make the pupil diameter less, only at night, and reduce the symptoms.
Но этот решаемый, говорит, вопрос. Многие пациенты в последующем привыкают к этому, то есть к оптическим побочным эффектам, но иногда он назначает пациенту в ночное время пилокарпин или бримонидин для сужения зрачков. In ours, optical side effects only.
The main is halo and glare. Yes, because.
Назначает пилокарпин либо бримонидин, если, то есть пациент продолжает жаловаться.
На какое время максимум можно назначать?
How long you prescribe pilicarpine?
Usually, you ask the patient to not use every day. To use, for example, if the patient will take the road at night, because with time it tends to reduce. There are very, very few cases that patient ask at the removal of the ring. I mean, 1 in 1,000. Very, very few, because of the disability in glare. So in most cases, it's not a major issue because the visual acuity gain is more important than the side effects.
1% of pilicarpine, 1%?
No, less.
Pilicarpine.
Yeah, 1 to 3%. Yes.
В общем, он назначает пилокарпин не каждый день. Он назначает пилокарпин, если, например, пациент планирует поездку ночную, какие-то ночные мероприятия, он назначает перед этим закапывать, он говорит, раз в день, раз в 3 дня, раз в неделю, а иначе нет. Или же бримонидин. Значит, каждый день. Значит, каждый день. Если он говорит, пациент уже продолжал жаловаться, очень редкие случаи, он говорит, 1 из 1000 он заменяет кольцо. А так, во многом, говорит, пациент остается довольным в дневное время. If patient has some only nighttime activities, he must drop every day, one time?
Yes, in some cases, yes. But when you evaluate the patient and you know this information, or if the patient has a very a big pupil, a 6 millimeters diameter pupil, you can change your surgical plan to a 6 millimeters optical zone.
Это надо. Он говорит, предварительно надо беседовать с пациентом, если у него действительно такой режим, ему имплантируют действительно размер больше. Предварительно надо беседовать с пациентом, узнать его режим. Если он имеет такую ночную активность, то есть ночную работу, то желательно до операции рассчитывать все это, учитывать и имплантировать кольцо большего размера.
Спасибо. Еще у кого-то вопросы?
Сауалларын беріп қойман деймін.
Айторин. Тогда у меня тоже очень много вопросов. Ладно, сейчас пока. Время, да. Ну, сейчас как мы поступим, коллеги? 5 минут перерыв какой-то, да? Потом продолжим или что? Some drinks and snacks, maybe. 5 minutes.
Okay.
Yeah.
Thank you.
Коллеги, мы продолжим. Следующий докладчик, доктор Ананд Партасарати, главный хирург и медицинский директор Центра зрения и хирургии глаза Ченнай, Индия, и по совместительству является консультантом и хирургом клиники SAIF-OPTIMA. Доктор Ананд Партасарати представит несколько презентаций. Первая называется «Смотри ближе, иди глубже». Как интраоперационная УКТ роговицы помогает при послойной кератопластике. Please.
Thank you so much, Dr. Iqbal and the SAIF-OPTIMA team for allowing me to be a part of the presentation and of course being such a good host. I love coming here. I think thank you for that. I would also say a big namaste to all of you who I have not met from India. I've been asked to speak about a bit on lamellar keratoplasty, and I'll try and see if we can keep it a bit interesting with some case presentations as well. And it's an open thing. We can have it interactive. If you want me to stop in the middle, not an issue. All right. So it's been more than about 100 years since the first corneal transplant was done, which was in about 1905. So we're about around 125 years since the first surgery was done. But what is probably interesting is that lamellar keratoplasty is not an approach. It has been there in 1963 as well. So when you're looking at keratoplasty, it's not really a new approach. And I've had the opportunity to see and observe Dr. Gerrit Mellis. He's one of my mentors as well. And broadly, the outline is about advantages of LK, optical lamellar keratoplasty. I'll see if we have time for therapeutic lamellar keratoplasty, endothelial keratoplasty, and also about femtosecond if we have time. Now, this is one patient of keratoconus. The right eye undergone a PK, very, very good vision, has best corrected vision of 20/20, but the endothelial counts are about 830. While for the other eye, we did a lamellar keratoplasty. The vision is also 20/20, and the endothelial cell counts almost 2,500 plus. So the advantage is that we know for a fact, because there is loss of endothelium after keratoplasty, usually the patients who have good endothelial cell counts will have good vision rest of their life. And I did a part of my fellowship in Singapore, and where we actually combined, looked at outcomes of the Singapore and Asian. We find that the outcomes are not as good as you get them in the US. There are problems of allograft rejection. There are problems of late endothelial failure. But almost 60% of the grafts have this problem of endothelium. So if you can shift to a lamellar-based approach, either for the endothelium or for the anterior cornea, the outcomes are likely to be much better. From the switch, we find that longer term outcomes, 10 years, 12 years, 15 years outcomes of lamellar keratoplasty are definitely actually much better than PK. Now there is an option of causing what we call focused replacement of lamellar procedures. So where there is a problem, you replace. You don't change the whole cornea. So you have anterior lamellar to replace the diseased stroma while maintaining the endothelium. So which basically includes DALK or even microkeratome assisted lamellar keratoplasty. You can use posterior lamellar keratoplasty or endothelial keratoplasty depending on the procedures like DMEC, DSEC, DALK. Now, what are the advantages of a lamellar keratoplasty? In an Asian or if for that matter Indian setting, it is predominantly an extraocular procedure. You can give a stronger eye. You can use lamellar grade tissue. You don't need optical grade tissue each time. The risk of allograft rejection is less. It is not zero, but less than about 1%. There is very less risk of endothelial decompensation. If the ocular surface is maintained, vascularization is no longer important. This leads to longer graft survival. Now, there are levels of dissection. If a cornea has 500 microns, if you do superficial, maybe the top 150 microns, it's superficial. You can go manually up to pre-desmetic layer, which is about 80%, 90%. And you can go down to the desmets or Duas layer now, where you can really go down to the last 20, 30 microns. And variation in the techniques can give you the depth as per the corneal disease. Now, femtosecond assisted lamellar keratoplasty still in evolution, but usually we know that up to 200 microns with the femtosecond, you usually get fairly good results. There are multiple techniques for DALK. You can do the big bubble, you can do the manual, MELIS, hydrodissection, viscodissection, and I prefer the first technique, the big bubble technique, which I find actually has very good results. Now, what is the big bubble technique? You are using a needle or a cannula, go into the deep stroma, separate the descemetes in the dua layer from the posterior corneal stroma. What that does is you retain the inner layer of the cornea. Just a short video of how this is done. So you do an anterior lamellar keratectomy, that's about 200 microns of the superficial cornea you remove. You inject a bubble, you release the bubble, and then with very carefully you remove the posterior stroma, and this is the duas and the descemet layer, which is absolutely clear. You then go back with the cornea, suture it in place, and that is the end of the procedure. If you're lucky and you say the right prayers, you can finish the surgery in 45 minutes. But in case you do have a difficulty in getting the big bubble, the procedure can take double that time. We did describe the small bubble technique a while back on trying to utilize the small bubble technique to increase the success of the big bubble. So this was with my mentor, Dr. Donald Tan, which was a while back as well, where we basically decided that you need to improve the success and the predictability. So you do an anterior lamella trephination, which is quite standard. Here we are using the HANAs. You do a dissection of the anterior stroma, usually about 50 to 60%, with either a crescent blade or if you have lamellar dissectors. Now you're in the last 40 to 50%. We can use a needle, you can use a cannula. I think it doesn't really make a difference. You inject the bubble, you get the big bubble. Now at this point, we make a very small paracentesis, put a small air bubble in the anterior chamber. Now what the small bubble does is actually delineates and tells you whether you have the big bubble, because sometimes visibility can be tricky. So this small bubble which goes around the big bubble and tells you whether you have the big bubble or not. You then release this bubble and the small bubble comes into the center. So now you have released the big bubble and you now, through this incision, you can actually remove the posterior stroma. This is just a small use of physics to make sure that the success of the big bubble is good. You can use Ulmer scissors, you can use a good vertical warners, you can go around, excise the posterior stroma, and once you have that, you're in the duas layer, which is basically the last 20-30 microns. This leads to complete bearing of the descemet layer. It is actually very clear, almost glass-like. And then the donor is sutured. Of course, you need to make sure that you remove the descemets because this is important, and you can use trypan blue to make sure you've removed all the descemets membrane. The rest is quite standard. You go around, use a double continuous suture, and then suture it in place. You can do it manually as well, both on the donor and the recipient. Occasionally we do use this to give a good dissection if it's very superficial, and then if for superficial corneal scars you can use the manual technique as well. You have multiple dissectors, you have gill knives, you have the Morley knife, you can use crescent, you can use mini crescent. There are multiple options. Sometimes when you've done posterior anterior lamellar keratoplasty, you find that the scar is still there. You can actually go back, you can do an Anwar big bubble, and you can get complete dissection of the descemetes, and that does give good vision as well. Now the technique has been described. What about vision? And we described the visual results as a presentation in ASCRS and ESCRS a while back, where we found that the big bubble techniques achieves better results than manual for DALK cases. This was presented in the ESCRS a while back, where we looked at comparing 32 patients of big bubble technique combined with 32 cases of the manual technique. we found that when we looked at PK versus DALK versus manual technique, the visual results of the big bubble technique, where we go down to the Descemet's, is as good as that you would get in a penetrating keratoplasty as compared to a PK. And this was, of course, with multivariate analysis as well, where we corrected for all the age, diagnosis, and recipient size. This is just a more detailed option of that. Now, there is an important part about what is intraoperative perforation. Now, DALK has a perforation rate about 10 to 15%. In PK, the problems are graft rejection and graft failure. So when you look at all the outcomes of steroid use, the chances of graft rejection and graft failure, DALK should be the preferred option for anterior stromal diseases. We have also published a while back about use for infectious keratitis, and this actually won the best poster award in the American Academy in 2007, where we showed that it can be done for infectious keratitis as well. We have described it for acanthamoeba keratitis as well. And a lot of these patients actually initially take slightly longer in vision recovery, and it is possible to actually get good vision provided you make sure you remove all the infection. For Pseudomonas as well, it is possible. This patient had fairly severe Pseudomonas keratitis, not responding because of multiple drug resistance, and we did with the lamellar keratoplasty for both of these cases. A short video of how this is done. Oops. Now, this is a patient with a fairly early stage of microbial keratitis, and in this we are following the procedures. Remember, therapeutic DALK is slightly different from manual DALK, wherein you need to probably not go with the big bubble, but in acanthamoeba it is possible to do big bubble, but you need confirmation. Now, you do an anterior-lamellar keratoplasty. You basically remove the anterior stromal layers just like we normally would do. We would go very, very slowly, making sure we do not have a perforation, because we know that perforation leads to poorer visual outcomes. And that is a fact that has been proved by multiple studies, that a perforation in a patient with infectious or microbial keratitis, could be fungal, could be acanthamoeba, could be bacterial, leads to poorer visual results. The concept of the dissection is actually quite same. Oops. It's not allowing me to scroll, but all right, I'll probably skip this part. I'll just go one other video which is done by my colleague from Arvind, wherein they used it for fungal keratitis as well. Now, here you are doing a lamellar dissection, you are injecting the bubble, and the aim is to debulk the infection. Aim is not to get the big bubble. You want to make sure that you reduce the load of the microbiology, so that when you are actually giving them the medicine, the effects are much, much better. The concept of rest of it is very, very similar. In the paper, we actually compared DALK with therapeutic keratoplasty, and we found that DALK, if there was no perforation, works well across all etiologies: bacterial, fungal, acanthamoeba, even culture negative. If you looked at visual outcomes, DALK did definitely better than the other two. What was important was perforated corneal ulcer, especially for keratoplasty, really affected visual results. This is the anterior part of it, and I'll pause my presentation before I touch about endothelial keratoplasty, and if there are any questions, I'll be very happy to take.
Thank you. Some questions, please.
I think he needs the mic so that people...
Very good presentation, congratulations. A question is, we know that the ideal dog with big bubble would be with the type 1 big bubble of the dual layers, but in very advanced keratoconus, the rate of type 2 big bubble is much, much higher, so there is a higher risk of perforation. So do you, in those cases, very advanced, prefer to go straight to manual layer by layer instead of big bubble?
Yeah. I think that's a good question. The grade of yeah, okay.
Доктор Таркветти спрашивает, что вот он показывал технику Big Bubble, когда вот между стромой и эндотелием вводится воздух, и в последующем остаток стромы удаляется, остается только пленка эндотелия. Он спрашивает, в развитых стадиях кератоконуса это чревато опасностью перфорации той пленки, эндотелии пленки, и предпочитает ли он технику просто послойного удаления остатков стромы, чем метод Big Bubble, потому что в некоторых случаях он потом чреват опасностью перфорации.
So for more advanced cases, you would prefer the manual technique. I think the thinnest layer of the cornea, where it is, we have patients who are 150, 200. Yes, Big Bubble can be tricky. So you definitely would not first do an anti-lamellar keratectomy. You would, if you have a chance, if there is no, I think for me, is there any Descemet's level scar? I do an OCT for all patients before surgery. Is there any history of hydrops? So those are the three indications for me. If there is a chance that there is a scar, sometimes apical scars, which extend to the Descemet's on the OCT or on slit lamp examination, bubbles would be a bad idea. You would go for manual technique. Now, just a small corollary for very advanced cones, you will have a fair amount of Descemet's, so they tend to have a longer visual recovery because the folds are there. So we usually tell them that the vision recovery, but for a patient who was maybe 0.001, any improvement is good. And they actually, in terms of visual results for keratoconus, they are probably the best of the whole lot, just like PK.
Доктор Ананд отвечает, действительно он согласен с доктором Таркветти. В таких развитых стадиях кератоконуса, когда есть уже, то есть в анамнезе есть острый гидропс, или же рубцы, связанные с эндотелием роговицы, то есть есть риск перфорации эндотелия во время технологии Big Bubble, он предпочитает использовать ручную технику, то есть manual техник, но при использовании ручной техники зрительные результаты получают не быстро и не очень хорошие, как при технике Big Bubble. То есть если есть возможность, то есть он делает перед операцией OCT и проверяет целостность эндотелия с помощью OCT. Если она целая, то есть не нарушена, то он предпочитает Big Bubble. Нет, то ручную технику.
Спасибо.
Еще какие-то вопросы у кого-то?
Okay. Yes, sure.
Dr. Anand, thank you for good presentation. And my question on glaucoma and on glaucoma in patients with corneal problems. Do you have any experience to do DALC in glaucoma patients? And what method of intraocular pressure measurement you prefer after and before?
There are, I think, 2 points to glaucoma in keratoplasty patients. Now, in about 30 to 40% of PK, that is a full thickness graft, 30 to 40% do tend to have a rise in intraocular pressure. 30 to 40%. That's why yeah, I mean probably about a year down the line because of the sutures and also the primary disease. Because the steroid use, as I showed in my graph, in its pre-existing glaucoma can worsen after PK. In DALC, I think if patient already has glaucoma, you need to manage the glaucoma well. The advantage, as I said, with DALC is the steroid use is less. Now, the question is about how do you manage the glaucoma and measure the pressure. I think the ICAT tonometer is probably the best, and I think that's what Dr. Iqbal also uses here, which is probably the most accurate way of measuring the intraocular pressure. Now, in terms of the management of the glaucoma, it is not going to be any different. You can do a trab, you can do a tube, you can give eye drops. Of course, no problem. All, not for the lamellar grafts, no. It doesn't increase the chances of rejection. But just a corollary again, for patients with viral stromal keratitis, most probably HSV, prostaglandins would not be my first choice. So the primary etiology becomes more important. We would then prefer timolol or the alpha blockers, or even now there are many newer drugs, the ripasudil. But we have seen patients of recurrence of HSV keratitis with prostaglandins. So you have to be careful about that.
Which steroid do you prefer?
Pred is my preference because the chance of IOP is lower.
Чуть-чуть я поясню. Вопрос был в том, что как сочетать трансплантацию роговицы и с глаукомой в общих чертах. Да, потому что при пересадке, как мы знаем, стероиды очень много применяются. И доктор Ант высказал свое мнение, какие капли. И, возможно, исходя из нашей практики совместной, мы сейчас предпочитаем проводить хирургию ахмедами клапана. То есть это очень удачно. То есть другие хирургии неэффективны, можем сказать. Так не сказать, что неэффективны, но в большинстве случаев, к сожалению, эффект не длительный.
Глаукома является злокачественной.
Да, совершенно.
In what?
If have glaucoma,
Keratoplasty?
Is usually malignant.
See, I think it is how early you pick it up. What are the intraocular pressures at start? If you monitor the pressure early, you can reduce the frequency of the steroid, start the glaucoma drops. The glaucoma as such probably slightly more difficult to manage, but the response to treatment, response to surgery for glaucoma will be the same that any normal patient of glaucoma will have. It's not that it's more, the chances of glaucoma are higher, but the response to treatment is the same.
What about condition of epithelium after Ahmed valve implantation? Is it harmful?
No. The glaucoma, I think, will cause any advanced, because I think there are 2 points here. One is, what stage would you implant the Ahmed glaucoma valve? There have been studies where they're looking at tube versus shunt versus trab, wherein you're putting the trab, you're not doing trab, but you're putting a tube in early glaucoma, right? We do know for glaucoma to be managed, the pressures need to be normal. When you're putting a tube in advanced glaucoma, let's say a excavation of 0.8 or 0.9, where end-stage glaucoma, the graft is going to be a slightly longer graft. The glaucoma is going to be advanced. If the graft fails, you have epithelial problems. So it depends on when you use it. If you ask me if you want to use, would that be my first choice in a patient with graft? Tube, no. I would prefer trap. Okay. Now, no. As the first choice, no. A first choice would be a trap. The second choice, probably a tube would be an option. But the tube will bring the pressure down significantly more than a trap. So if the pressure is 40 after keratoplasty, then you're looking at a tube, because trap may not work that well. But we have patients in which the tube can be put in the posterior chamber. Better for the graft rather than putting it in the anterior chamber.
Of course. Тран пояснил, что все-таки первым этапом традиционная хирургия трабекулоктомия предпочитает, потом, если неэффективно, уже клапанная хирургия. Ну и в нашей практике, опять я могу сказать, что именно после витриктомии помещение трубки в заднюю камеру более безопасно. Posterior. Yes. After vitrectomy and the Ahmed tube and the posterior chamber. Еще один вопрос.
Добрый день, у меня такой вопрос. При методе Big Bubble при введении воздуха в строму не всегда опускается десцементка, не с первого раза. Что надо делать, чтобы он с первого раза опустился, десцементка? И что надо делать, если он не опустился с первого раза?
What you do if after first injection of bubble, the cement is not attached.
Not detached.
Detached, yes.
Okay. You can do up to maybe 2 injections. Usually, my preference is to do at least 2 injections before we say bubble doesn't work. Remember, there is the deeper you go, the more the chances of bubble. So that's the advantage of doing a lamellar keratectomy and then going to the posterior stroma, so that the chance of bubble, the injection is closer to the descemetes and separation, air emphysema and separation is easier. If you're doing it with the full thickness, you can still get the bubble provided the depth is right. I have access to the intraoperative OCT, so we are able to place the needle closer to the descemetes. We can do it under OCT control.
Если оставить больше стромы, то есть действительно шанс, что вы не попадете и не отслоится десиметка. То в таких случаях он советует побольше утончать. То есть побольше убрать то есть строму. В таком случае более удачно получается. Он до 2 раз, оказывается, пробует. Если не получается, то он использует интраоперационный OCT. То есть есть такая проблема.
But if you understand, if you want me to ask, you asking me, is there a perfect way of doing it? I think it depends on whether you had a drink last night or whether you said the right prayers when you start surgery. Nobody gets 100%.
Drink what do you mean?
Whatever you want to drink.
Это зависит от того, что еще вы, в общем, перед этим ночью выпили немножко или нет. Шутка, да? То есть он имеет в виду, что it depends on surgical skills.
Yes.
От этого, от навыков зависит.
Спасибо. Please,
the next part is about endothelial keratoplasty.
Okay. Следующий доклад посвящен эндотелиальной кератопластике.
And I'll touch basically about what is more commonly done, at least in our part of the world. Okay. Presentation, yeah. We started off posterior lamellar procedures with DLEC, which was described by Mark Terry. We then shifted to DSEC, and then we have, of course, DMEC, which is now a lot more commonly performed. But in my part of the world, where you tend to get slightly more advanced cases, we prefer the DSEC in about 80% of the cases. This is DLEC. So you have a cornea which is edematous. In this, you actually do a dissection of the posterior part of the descemetes and the stroma, and the donor is cut similarly, and then with air bubble you attach the DLEC graft. In DSEC, there is no removal of tissue. You are using basically additional tissue and you add on. So the endothelial layer is replaced with clearing of the stroma with a stroma descemetes membrane endothelial complex. In DMEC, only the endothelium is replaced with the descemetes in the stroma. There is of course now mention of PDEC, where you add in the Duas layer. Now the current indications include pseudophakic bullous keratopathy, which for us is the most common, Fuchs dystrophy, repeat grafts, and you can use it for TAS or ICE as well. Now what are the advantages of DSEC? It's a smaller incision, closed eye surgery. There's a minimal change in refraction, usually hyperopia, faster visual rehabilitation, and reduced risk of rejection because of lesser tissue implantation, and that has now been proved with multiple studies, and relative ease of repeat implants. The damage to the endothelium is basically slightly higher, which is about 20%. You can have problems of donor dislocation which need to be managed, and they are usually for early forms of endothelial decompensation. If you have anterior stromal scarring, DSEC and DMEC both could not be done. So this is a video for DSEC, and this was the pull-through technique which I'm showing you, wherein you mark the anterior stroma up with about 8 millimeter, which is usual size of the graft that I implant. You put an anterior chamber maintainer.
You also have another side port, basically for removal of the desmids. And this is for the insertion forceps from the opposite side. This is the reverse Sinski, which helps to remove the diseased desmids membrane. In Fuchs dystrophy or scarred desmids membrane, it's a good idea to remove the desmids. Very occasionally, you can actually still keep the desmids if the desmids is not scarred or it is bullous keratopathy. You remove the desmids, it comes off usually quite easily. Make sure you do not leave tags. This is important because this can affect the attachment of the graft. An inferior PI is a good idea because you are leaving a full air fill to prevent pupillary blockage. This is the IOL glide, which basically I have a problem. Can we go out of the file and then see if we can? I think the computers.
Извиняемся перед аудиторией, небольшие технические проблемы.
I can play it directly. Yes. Okay. So these are the side posts. I'll probably rush through this part. And you can make out a scleral tunnel, which is about 4.5 to 5. If you are comfortable with the manual small incision cataract surgery, you can combine it with the manual small incision cataract surgery, combine it with DSEC as well. So if you're doing phaco, you can use different wounds, or you can make the scleral tunnel, do the phaco, and then enlarge it and insert the graft. Now, of course, there are some devices for folding as well, where you can insert a folded graft into the chamber. So, PI, I hope this runs through the whole thing. So this is an IOL basically insertion glide. You have, of course, the Busin glide, but if you really want to keep the cost low, this is a good modification. So this DSEC graft has already been cut, and we are using incorrect file, is it? Okay, maybe just go to the presentation. I'll see if we have another video for the DSEC.
К сожалению, опять технические проблемы. Но сейчас с бурным развитием катарактальной хирургии по классификации, я думаю, практически у всех хирургов бывали такие случаи после операционной булезной кератопатии, нотариальная дистрофия. И поэтому количество таких кейсов, думаю, будет увеличиваться у нас, прогрессировать. Пожалуйста.
Yeah, so this is just an ASOCT showing a lamellar transplant which has been attached, and this is how it looks post-operatively. And the advantage is you can actually use one cornea for 2 patients. With DSEC, it's very much possible. Now with limbal transplant, you can use it for 3 patients as well. So 1 cornea for 3 patients, very much possible. And we described this, and we did get some press study work on that. Now there is a new kid on the block, femtosecond lasers for keratoplasty, where we can use the femtosecond technology for cornea work. We did describe this as well in 2008, where we were among the first ones to actually describe it. Now, in lamellar keratoplasty, this is a video of granular dystrophy, wherein the anterior stroma is affected. This is the donor corneal button cut with the femtosecond laser, and this is matched by about about 200 microns is cut. Then the recipient, the patient's cornea, is cut. This is a laser with a different laser pattern, which is spiral, very similar to what we get with SMILE. So donor and recipient matched, and since these are usually about 150, 200 microns, you can just peel it off. You can separate the flap, almost like a free flap. Use sometimes in slightly thicker stromal opacities, there may be a bit of adhesions. So you may need a bit of lamellar dissection because the femtosecond laser will not be able to do such a good job. You then peel it off. If you want, you can do additional PTK if you have some irregularity of the recipient stroma. The donor, which is cut with the just maybe about a 0.25 difference, is then basically adjusted. Make sure you have a good fit. The edges do not have overlap. You dry the edges just like you would with a sponge. Wait for about 10 minutes, put in a bandage contact lens. And from this, if for early corneal dystrophies, they actually do quite well. And over a period of time, some of them, even without sutures, they respond quite well. Remember, femtosecond can be used for full thickness. This I have shown for lamellar keratoplasty. These are electron microscopy pictures of the cut with the femtosecond compared to that with the blade. So the results are actually very, very good. So with the femtosecond technology, the quality of the rim, the amount of sutures you use is minimal. The vertical cut edge on the histopathology shows exactly what we would want with the technology. We did do some studies initially to show that sometimes you may require a couple of passes to get the results with the femtosecond. So in conclusion, the DALC surgery with complete bearing of the Descemet's membrane with the big bubble technique provides good visual results, as good if not better than PK. It gives better graft survival with no risk of graft rejection. Desec or desec may be the preferred option for endothelial dysfunction. Targeted replacement of the diseased cornea is my preferred method for corneal transplantation. FLEC or femtosecond laser assisted keratoplasty is an evolution for EK, and precise lamellar dissection at the depth with diameter settings is possible in human corneas in femtosecond laser procedures. Thank you for your attention.
Thank you very much, Dr. Arndt. I hope soon starting in the general keratoplasty, because in clinic buying the new laser Zimmer, okay. Z8, maybe next visiting starting.
That'll be nice.
У кого какие вопросы?
Dr. Tokedi, sure.
Do you have any experience with the DSO procedure with residue Descemet stripping only plus residue?
I personally have not done, but I know that there are some published reports. I know some doctors do practice that. Fuchs is not a primary indication that we see that much in our part of the world. I'm sure you see more in America, they see more. It makes sense to me that you remove the disease part and then the normal part kind of grows. But Fuchs results are generally very good with PK, EK, DMEC. But for advanced Fuchs, which I tend to see more, I find that that may not be an ideal procedure. But I know that here also Dr. Iqbal has also used ripasudil eye drops for Fuchs, and the results are equivocal. So I'm really not sure where this fits in, but for early cases where you've diagnosed Fuchs and you want to make sure it doesn't progress. But the problem with that is if you have done that with the procedure with the reverse Sinskey, you've already scarred that area. So you're then reducing the chances of future lamellar surgery. What are the results with ripasudil, Dr. Iqbal?
In our presentation today,
Huh.
some as case in the last presentation.
Okay. Okay.
Вопрос был в том, что доктор Таргевети спрашивал, вот, если честно, я про этот метод не знаю, поэтому я точно перевести не могу. То есть метод, который удаляет только эндотелий с помощью синского.
Дистометрексис.
Да, дистометрексис, он считает достаточным и эффективным. Доктор сказал, что он тоже не имеет такого опыта. Ответ такой был, не имеет такого опыта, но читал, что есть такой метод, он достаточно эффективный, но имеет, конечно, свои определенные недостаточности.
Very long time rehabilitation patient, да?
Свои какие-то определенные.
X-files.
Очень долго.
Метод я не знаю.
I'll go with pterygium first. Yes. Yes.
Все?
Next.
Просто я не слышал про это. Он тоже читал, оказывается, про этот метод, но не использовал, да? You have not experience.
With no, Dweck, no.
Only diametrology.
Correct, because I don't see early cases. I see very advanced cases where those modalities would not work.
Okay. Продолжим тогда.
Okay.
Третья презентация посвящена, называется Secret Files, секретные материалы.
So just some short videos of something. I think those are important additions to every ophthalmologist's surgery protocol. So I'll do the voiceover so there's no confusion. So an ideal graft has multiple properties. You have, sorry, just let me go back. You have adequate fibrovascular tissue, you need to have a generous graft, a thin tenon-free graft, adequate stabilization of the limbus with superior and inferior edges. So you do get very, very severe cases, and these are some case reports of recurrent pterygium, because the recurrence depends on the primary procedure. So if you have done it well the first time around, these scenarios are quite rare. And remember that the recurrence is worse than the primary disease because they have a lot more fibrous disease and it becomes a lot more tough to manage. So I call it the perfect technique, that is pterygium extended removal followed by extended conjunctival transplant. That is something that I prefer to follow for severe recurrences. Now, what are the principles? Principles are replacement of the normal stem cells. So you can do a mini slit. You do wide excision of the subconjunctival tissue, limiting the fibroblastic activity. You can use mitomycin C for young and extensive pterygiums. Reduction of the post-op inflammation and its byproducts. So you give a fair amount of steroids, and you remove the abnormal pterygium epithelial cells. You can combine with AMG if you do not have enough conjunctival tissue. This is the post-op just of one of the patients. Now, this is an 82-year-old lady operated for primary pterygium 15 years back. Regrowth of the pterygium noted about 6 years back. Recurrent attacks of pain, redness in the last 6 months. Visited the biggest hospitals in my part of the world. Usually given eye drops and usually gives temporary relief with eye drops. So this is, if you can make out, this is how it looks on table. You got a very broad and a central part which is extensive. you have an area which is actually started thinning. So you have a bit of thinning as well because of the Dellin effect. And that's probably the reason she's getting recurrent attacks of inflammation pain, and she's actually not very comfortable. So both require the treatment. You need to treat the extensive pterygium, and you need to treat the defect, the thinning that is actually started. Now the OCT shows maybe about 20-30% left over. And so the diagnosis is basically recurrent pterygium with corneal thinning. The plan is recurrent pterygium excision with the perfect technique with tectonic tenons transplantation. So you basically excise the head of the pterygium. They tend to bleed a lot more. Just remember that. They would have a lot more bleeding. You keep, because tenons is plentiful, you can basically use as much as you want. Patient will never get a tenons deficiency. So you can remove as much as you want, keep that. You do an extensive dissection. You can use diamond burr as well. Remove all the subconjunctival fibrosis, scleral fibrosis. Needs to be done meticulously, and sometimes you need to do an extensive removal. An important point about making sure that you do not get a recurrence is to remove the subconjunctival fibrosis. This is, you can mark it. Oh, this is a repeat. You can mark it, but the approximate size of the graft needs to be equivalent to the size of the defect that you're creating. So this is the removal of the subconjunctival fibrosis. You can make out it's actually piecemeal. It is not usual that you would get this. In a primary pterygium, it tends to be like a sheet. In recurrent pterygiums, it comes out piecemeal, so you need to keep working at it. And I prefer to go at least till the area of the limbus. The graft is then taken out and put in place. You measure the defect. Remember, it's a lot more time consuming than a primary pterygium. The defect tends to be slightly larger as well. In this patient, I did not use the amniotic membrane, but if the defect is really large, you can use amniotic membrane. You can make out with the fibrin glue. I didn't put sutures, but there is a small buttonhole because the tenons in these patients is never that easy to take out. You wash, of course, and now this area is where the Dellins is. You dry that area. The tenons which you have already harvested, you place it on that defect. You can use additional layers of tenons, it's really not a problem. And you can put multiple layers. Some people use amniotic membrane as well in multiple layers. I find that the tenons actually works better because there is a bit of tensile strength. Remember, you can't use it in the central part of the cornea. You got to use it in the periphery because it will opacify, it will not be a clear part. So the collagen structure of the tenons is slightly different from the collagen structure of the normal cornea. So it will appear slightly white. You can stick it in place with a bit of fibrin glue, and you do overlay sutures. You do not suture the tenons, but you put sutures around it like a figure of 8. And once you have, of course, make sure that there's enough tenons in place. You do a figure of 8 suture. It helps to keep the tenons in place. Now remember, tenons can be used even for corneal perforation. Small corneal perforation this size works actually quite beautifully with a bit of fibrin glue. This I use for a Dellin, and over a period of time it actually absorbs the epithelium, kind of fills up the gap. Of course, you can see the patient is 82-year-old, moving the head. It's not easy for the patient as well. But we basically did an overlay suture. I'll just see if I can rush to the end. Unfortunately, I think that is the end of the video. But this is just one way of actually using tenons. I will touch upon one any questions before I go to the second short video? Or should I cover all the videos?
His patient has comorbid some diseases like the
Rheumatoid. Good question. We screened that. We screened all the rheumatoid, 82-year-old, no joint pains, actually quite active lady. So no arthritis, immune screen negative, CRP, everything was negative. Just that the Delin was because of the recurrent pterygium.
Вопрос, если нет, продолжим. Next, please.
Yeah. This I would show is the Gunderson flap, which I find probably underutilized for bullous keratopathies, for patients with poor visual prognosis. This was a patient who had an infection, and with this stable ocular surface, you can actually get very, very good results. This patient had a Gunderson flap post-op. You can make out no staining. For patients with poor vision prognosis, sometimes even for corneal perforations, it's an option you can use. Described actually in 1956 by a gentleman, and if you do it well, you can actually make out the anterior chamber. So if you get a thin graft just like pterygium, there's no epithelial defect, you can make out. This patient had bullous keratopathy, advanced glaucoma, nil visual prognosis. So we just do a Gunderson flap, you can actually make out the anterior chamber details, you can check pressures and everything that you would want to do. So the point is to basically measure the thickness, the length, and do a tenon-free conjunctival flap. You need to do a 360-degree peritomy and then shift the graft on. Now, even if you have a buttonhole, it's not a problem. Like this patient, I have a buttonhole, but with fibrin glue, the conjunctiva actually grows quite well. You put a bandage contact lens, most of them actually do quite well. They look like this, very thin. So in conclusion, Gunderson flap is an elegant procedure, provides options for eye surgeons, for perforations, for viral keratitis, for even you can do half flaps for peripheral perforations, works quite well. So,
It's not forgotten for us.
hmm?
We do it here.
Yeah? Okay, great. Conjunctiva.
Kant, plastica, Kant.
Okay.
As outer.
Only the outer, okay. I didn't understand.
Outer name is Kunt. Plastica, outer by Kunt.
Okay, nice. Okay, that's good to know.
It's Kunt method.
Доктор Углубек, я прошу вас до этого видео птеригиум, небольшой ваш комментарий.
Я
Им интересно просто у нас
задал вопрос, почему у него есть лимбальная язва в области лимба. Я спросил, есть ли у него какие-то системные заболевания типа ревматического артрита, потому что это состояние часто сопровождается после ревматических заболеваний. Он ответил, что никаких системных заболеваний у него не было. Второй вопрос был по поводу того, что он показал нам операцию пластическую, мы называем пластика по Кунту. Правильно? Мы же это делаем. Он говорит, давно забытый метод, то есть хороший, а мы это же давно, то есть мы это не забыли, мы делаем это очень часто.
All right, this is my last one about aphakic bullous keratopathy, and we did basically struggle with some initial cases on how to actually have attachment of the graft, because especially in myopic eyes or large axial length. So a couple of hacks on how to actually do endothelial keratoplasty and in these cases. Now, there are some intraoperative difficulties. You have a deep anterior chamber, there are some iris defects because of prior surgery, you get hypertony during surgery, there is escape of air into the posterior chamber in vitreous, and you can get post-op hypertony leading to graft detachment, and you get higher rebubbling rates. So we try to solve this by trying to look at options to treat that. So the solution was the double infusion technique for aphakic bullous keratopathy, where you have a combination of anterior and posterior planar infusions to solve the problem. So you have volume in the anterior chamber and posterior chamber. So in this, if you have to basically do the surgery, in this we are doing an anterior chamber infusion for the vitrectomy and IOL fixation. And here we try to do it, I think, with iris claw. So we did a good anterior vitrectomy with the anterior chamber maintainer. You can put a 3-piece if you have a sulcus availability. So this shows that the sulcus placement is good, so we would not touch that. This is with the intraoperative OCT, wherein you can actually push in the graft. This was the push-through technique. You can monitor the, now you have an infusion in the pars plana, which provides the volume, so you do not have hypertonia. So the vitreous is already full. You can make out that the pars plana is already putting it. The infusion is on. You put in air bubble, so the air bubble doesn't go. It's definitely better than not having anything. You get a full air fill. You do a venting incision. Now you can make out on the OCT there are still some interface fluids. So you got to release that, and at the end of the procedure you can see the amount of fluids actually come down. You can use SF6. I prefer SF6 to air. So SF6 with the pars plana infusion gives you good pressure. It attaches the graft. This is a DSEC. And you wait for about 8 to 10 minutes. A full air fill important. And at the end you remove the pars plana infusion. This gives good attachment. You can make out on the OCT the attachment is actually quite good. Well attached donor graft at the end. Of course you suture the wounds if there is leakage, and that's the end of the procedure. I think these were the 3 short videos. And
доктор Ант закончил презентацию коротких видео. Если у кого-то есть вопросы. У меня вопрос просто в плане дискуссии доктору Торкетти. What prefer IOL fixation without Rex affecting, without absorbed?
My preferred technique is a 4-point sclerofixation with a Gore-Tex suture. I'm not a fan of Yemeni because I feel that the best place for the haptic is not to be embedded in the sclera. I'm afraid of the long term of this. And Gore-Tex is a suture that has been used in vascular surgery, so it will last for life. So you make 4 sclerotomies and make a 4-point fixation with Gore-Tex. It works very well.
under the flap?
No, without flaps. The main problem of this technique is you have to bury well the knots. Okay. Otherwise, you will extrude. There's extrusion.
Okay.
So if it's well buried, there is no need of a flap.
So this is, you remove the conch, then make 4 incisions in the sclera and draw the Gore-Tex through that.
Yes, in 4 points.
4 points.
So it's very useful to achieve a good centration because you adjust for 4 points.
Вопрос был в том, что какой метод фиксации хрусталика он предпочитает у пациента с афакией. Ответ, он использует специальный шов белого цвета. Я, если честно, видел его операции, он отправлял. Такой белого цвета шов, кортекс, да, он фиксирует в 4 местах.
Не рассасывается никогда.
Да, и в 4 местах, и у него были какие-то определенные проблемы тоже, он зашивал, еще покрывал. Этим тоже бывали случаи.
Я просто почему задал вопрос, прошу переводить. Вот с доктором Антом кейс был у нас, когда миопия высокой степени, предшествующая ретинальная хирургия, то есть как бы при склеральной фиксации у нас синдром гипотонии возник. И графт начал отслаиваться. Да? Возможно ли это было связано с тем, что именно склеральная фиксация была линзой? Просто у меня из своего опыта я скажу, что мы предпочитаем как бы iris-cloud fixation. В этой плане дискуссии я просто сейчас вспомнил этот случай, кейс, который рассматривали. Именно при ретинальной хирургии, там, склеральной фиксации, миопия высокой степени, иногда гипотония, это чревато отслойкой графта. Поэтому по поводу этого комментарий ваш.
In case it was patient after vitreoretinal surgery and high myopic, he performed scleral fixation, and after this intraocular pressure decreased and corneal graft was
Detached.
detached. Is it maybe is it may cause due to scleral fixation, or is not due to scleral fixations? It might be another reason.
Because the whole point was that it came from our discussions that you make the scleral incisions, there may be a post-op leak. Even if you glue, there may be slight leak. So, and we were struggling with high myopes, 28, 30. So we felt that this technique where you put in pars plana, raise the pressure, and do your anterior chamber with iris fixation, I find this probably the best for high myopes.
Thank you. Спасибо. Значит, next,
I'm done. I think this is
last presentation.
I think we can go to your next presentation, and if I have time, we can come back. Would that be okay?
Yeah, please.
Wonderful surgeries. Congratulations, Dr. Anand. I'd just like to add some personal experience with a new, not new, but a different technique for harvesting the conjunctival graft. Have you ever seen or used a pneumodissection technique?
A pneumodissection. I've used saline, but pneumodissection sounds interesting.
It's very interesting. You can get very thin grafts, just conjunctival grafts.
Nice. Let me try that. Present.
I would like to show you one of your cases from YouTube. Okay, can you explain it? Yes. Yes. Scleral fixation after PK. Okay. Good. That's your case. Your tail. Сколько ждать? 1 minute. Доктор хочет показать такой тоже случай. Он тоже немножко был вдохновлен его кейсами. Он хочет показать свой кейс тоже. То есть случай, когда фиксированная фиксация пользуется сквозной кератопластики. He was experienced and inspired with your high cases and would like to show his case. And I would like to show his case, don't he? He's very good.
Просто еще раз скажу, что сейчас доктор Таркетти хочет представить свой кейс. Вдохновленные кейсами доктора Ананда. Так, небольшое свое видео он хочет представить.
То есть ответный такой, как вебинар.
Алаверды.
После этого доктор Ананд покажет еще один.
So this is a patient with a fade PK. He was operated maybe 20 years ago. It's a phakic. So first of all, to avoid vitreostraction, you need to go through pars plana and do a good anterior vitrectomy because we work with forceps going through pars plana. And then you make you can use a 15-degree knife to make 4 sclerotomies. And usually when I'm doing in patients without PK, I'm using a scleral tunnel. But here I use the cornea as the way of access of the IOL to the anterior chamber. And then I will cut. And before I take out all the failed graft, I will pass the Gore-Tex. Otherwise, you to do it on open sky would be risky. So I just enter the anterior chamber and pass the Gore-Tex from one side and for the other side. Here I'm using a 23 gauge forceps. Today I prefer the 25 gauge to avoid the leaks. And I have passed it's a double armed suture. One side, one arm. Ideally, you should use this IOL if there's small loop, and you keep pushing and push the other haptic to the anterior chamber. And you can use the 4 points of suture to ensure a good centration of the IOL. And the anterior chamber maintainer helps us to have a stable chamber. So sometimes you fill up the chamber, sometimes we don't. And the most important here in this technique is to make sure you bury the knot, otherwise we will extrude through the conjunctiva. For sure, for sure.
Under the flap, not a good idea?
Yes, it would be a good idea, but you would need a relatively large flap because of the distance of the two sclerotomies. Would be a good idea, but it's very common, for example, in high myopes patients to have a very thin sclera. Sometimes it's difficult to get a good thickness, a flap with a good thickness. And then you go to the PK. It's a good technique.
Thank you.
Thank you.
Great.
This suture is called CV8, but it's actually is a 7-0. It's not 8-0. You have to give at least 3 knots, and to pay attention to not make it very tight. Otherwise, you have problems boring it, and you can have a decentration of the IOL. It can be a little bit loose, the suture, to allows you to make a boring without problem. 1-1-1. Yes. And the last one you hold with the forceps, and the assistants make it. Yeah. It's a good technique. Yeah.
Thank you.
Okay.
Thank you.
Thank you.
Так.
Thank you.
Следующий докладчик, наша коллега Хабибулаева Нигора Хусамна, выступит с темой оценка результатов модифицированного кросслинкинга при кератоконусе. Пожалуйста.
Здравствуйте, уважаемые коллеги. Спасибо за предоставленное мне время доклада. Спасибо гостям. Хочу вам предоставить свой доклад об оценке результатов модифицированного кросслинкинга при кератоконусе. Первый слайд посвящен статистике. Наша клиника впервые начала работать с конусами с 2010 года. С этого года мы начали применять метод кросслинкинг, и здесь показана статистика применения кросслинкинга пациентов. По росту вы видите, что с каждым годом мы пользуемся кросслинкингом все больше и больше, но придя к 2019 году и 2020 году в связи с ковидом у нас рост немножечко снизился. И потом опять идет рост графикой. В 2023 году, еще 2023 год не закончен, и у нас идет рост будущего. Почему рост будущего мы здесь показываем? Потому что идет рост эксимерой лазерной хирургии, и диагностика кератоконусов будет больше выявленных этих пациентов, будет выявление больше. И после эксимерой лазерной хирургии у нас встречаются ятрогенные эктазии. В следующем слайде мы видим, что сколько пациентов и сколько глаз было у нас за этот период. Количество пациентов было 1563, глаз 825. Процент обращаемости и выявления кератоконуса с Центральной Азии, это Узбекистан 88%, Таджикистан, Киргизстан и Казахстан 4%, а из Туркменистана 0%. Почему? Потому что она более такая страна автономная, из которых к нам не идут пациенты. Здесь представлена обращаемость из городов Узбекистана, и самый больший процент это Ташкент. Здесь соотношение мужчин и женщин. Мы видим, что мужчин у нас больше, это 67%, а женщин 33%. И средний возраст у них составляет 23 года, плюс-минусом 5 лет. По стадиям третьей степени кератоконуса было больше, чем вторая и первая. Здесь мы использовали приборы для кросслинкинга. В 2010 году мы использовали прибор UV-X1000, а уже с 2022 году уже более улучшенные модификации, пешка трейд, использовали этот прибор. Он более лучше, он показывает время, он показывает, отслеживает глаз, он более модифицирован, и им можно делать акселерированные методы кросслинкинга. Материал и методы мы собирали у наших пациентов из 96 глаз, 70 пациентов с прогрессирующим миопическим, с прогрессирующим кератоконусом, которым был выполнен кросслинкинг. Модифицированные методики ПИОФ – это частичное удаление эпителия роговицы с сохранением зрачковой зоны. Впервые их предложили нам индийские ученые Туши Ом Паркаш, Шурти Махадж и Рохит Ом Паркаш в 2012 году. Но в 2019 году, когда был у нас эскорс в Париже, мы начали применять этот метод. Мы собирали пациентов в течение 3-6 месяцев под наблюдением инструментально подтвержденным и документальным методами. При прогрессировании миопии и астигматизма более 3 диоптрий, среднее изменение центрального значения кератометрии 1,5, выше 1,5, увеличение максимальной кератометрии Кимакса более 1 диоптрия. И среднее уменьшение толщины центральной части менее 5%. Техника выполнялась частичное удаление эпителия роговицы с сохранением зрачковой зоны. В этой процедуре мы использовали 3-миллилитровый рибофлавин 0,1%, декстран 500 и 20% с использованием ультрафиолетового осветителя. Перед процедурой пациентам закапываем миотики, а для анестезии используем алкаин за 15 минут до процедуры. Потом производим деэпителизацию роговицы тупым ножом. Частично удаляем полосами, оставляем 2-3 мм оптическую зону, потом капаем рибофлавин в течение 20 минут каждые 2 минуты. После удаления эпителия мы проводим пахиметрию, чтобы убедиться, что толщина роговицы составляет более 400 микронов. После мы облучаем оптическую зону роговицы при мощности ультрафиолета 3 Вт в течение 30 минут по стандартной методике Дрезденскому протоколу на расстоянии 5 см от роговицы. Во время облучения мы закапываем рибофлавин с декстраном каждые 5 минут. После облучения поверхность роговицы орошаем раствором, физраствором. В конце операции закапываем антибиотики. После ставим бандажную контактную линзу с повязкой на 1 день. После процедуры пациентам назначаем антибиотики 4 раза в день в течение 10 дней. Стероиды назначаем через 5 дней после снятия линзы в течение месяца и любриканты в течение 2-3 месяцев по 3 раза в день. Кроме стандартной методики, мы пользуемся и акселерированным методом кросслинкинга роговицы. Он отличается от стандартного метода тем, что минута здесь сокращается на 10 минут, а ватты используем 9. Более ускоренный метод считается. Вот это анимация ускоренного метода. Проникновение рибофлавина под эпителий. Как происходит. Вот здесь показан пациент в примере до кросслинкинга, потом первый день, после снятия контактной бандажной линзы. Здесь мы видим стрелкой, что эпителизация еще идет. И на второй день роговица у нас вся деэпителизируется, прошла. Да. Это динамика остроты зрения в течение 2 лет, наблюдаемых у пациентов НКОС и КОС. Значит, НКОС до процедуры было 0,16, а после стало через 2 года 0,47. КОС было 0,43, а через 2 года 0,63. А это динамика сферы, цилиндров, изменений в течение 2 лет. До была у нас сфера минус 3,96, стало минус 3,5. Цилиндры были минус 5,74, стало минус 5,5. Динамика сферы эквивалента тоже до было минус 6,03, стало минус 5,21. Динамика К1 и К2. Значит, К1 было 48. Мы смотрим именно на первый месяц. Здесь идет рост, как вы видите, через месяц после кросслинкинга. Почему? Потому что идет деэпителизация. И сравнивается вот этот первый месяц и последние 2 года. Значит, было 48,62, стало 44,2. А К2 с 52,77 стало 52. Динамика кератометрии Кимакса. Тоже вот смотрим на первый месяц после кросслинкинга 58,82, через 2 года 53,78. Здесь мы сделали тренд-анализ на Кассия-2. Здесь тоже можно увидеть на примере у пациента. Вот здесь указывается 57,4 Кимакса. Это было через 2 года оно стало 55,2. И разница Кимакса минус 2,2. Идет снижение Кимакса. Здесь пахиметрическая динамика. Значит, это было до 427. И динамики оно улучшилось. Стало 464 толщина центра. Можно вот по месяцам тоже посмотреть, как идет динамика. Это глубина демаркационной линии роговицы. Демаркационная линия роговицы появляется через месяц. Глубина средняя 252, а в конце, через 2 года оно стало 257. Здесь вы можете посмотреть, что было до кросслинкинга. Здесь мы не видим демаркационную линию, а через месяц вот оно появилось в глубине 268. В заключение хочу сказать, что после этого метода улучшается зрение, острота, это НКОС, КОС, уменьшаются кератометрические показатели, уменьшаются показатели рефракции, образуется демаркационная линия в среднем 257 и останавливается прогрессия кератоконуса. Преимущество метода Radial Rose Pattern от традиционного кросслинкинга, хочу сказать, что оно менее болезненно, как во время операции, как во время процедуры и как после процедуры. Быстрое восстановление эпителия роговицы на 1,6 раз. Низкая частота осложнения – это хейзы, инфекционные кератиты, помутнение роговицы и возможность применения процедуры для педиатрических пациентов. Благодарю за внимание.
Спасибо большое, Рухсанна.
Спасибо.
Вопросы? Questions?
Was wondering, any of those patients, did you do any laser as well or only CXL? This is only CXL. Only CXL, okay. Well, the reduction of keratometry would be significantly more and the irregularity would be more if you do a laser as well, right? The clarity. So why would you prefer only CXL? My question, as
Доктор Ананд спрашивает,
Давайте, да, всем.
доктор Ананд спрашивает, у вас очень хорошие результаты, и достигли ли только это с помощью то есть кросслинкинга, или же вы им показалось, что вы сделали лазерную коррекцию?
Нет.
Настолько улучшение.
Кросслинкинга это результаты.
But stability was good. I think all 2 years stability was good.
Течение.
Он
ответил,
очень
just
хороший результат.
like a topography guided vision.
No.
I'm not sure if what I'm going to tell you is true because of understanding, but I realize there is a tendency of increasing in pachymetry, but maybe there is a small trend of steepening after 2 years. So are you going to treat again?
В течение вот этого периода, года, когда мы наблюдали за этим пациентом, был год ковида, и пациенты не приходили.
Вопрос он про то, что у вас пошел хороший результат, через 3 года стабилизация идет,
а потом
он рекомендует вам еще раз провести кросслинкинг. Делаете ли вы это или нет?
Нет.
It's only once.
Okay.
Once.
Retreatment only once. Okay.
Only one cross-linking. No retreatment.
Я просто хочу сказать, что здесь то, что вот почему зрение улучшается, мы действительно это наблюдали. Сфероэквивалент реально уменьшается, и с течением некоторых пациентов с течением времени, наоборот, этот сфероэквивалент мы наблюдаем, что именно уменьшается. То есть процесс уплощения роговицы продолжается по нашим наблюдениям. Такие кейсы были у нас, да.
Ну, если правильно объяснить, здесь были исключены те пациенты, которым были в последующем проведены лазерные дополнительные процедуры, правильно?
Нет, это именно кератоконусы.
Я хочу сказать, здесь были исключены те пациенты, у кого были не очень хорошие результаты.
Нет, мы здесь именно модифицированный кросслинкинг, то, что применяли последнего, вот эти все вошли.
То есть исключения не было?
Нет.
Был не очень хороший результат?
Нет.
Я согласен, просто он про это спрашивает.
Просто у нас были негативный опыт с применением трансэпителиального кросслинкинга. То есть реально трансэпителиальный кросслинкинг, мы потом перестали, сейчас в последнее время практически полностью отказались. Трансэпителиальный кросслинкинг реально во многих случаях пришлось повторно делать. То, что он говорит, то, что перевели.
We don't include to these investigations another method. For example,
only 2 years.
Transepithelial keratoconus.
С 2020 года до 2022.
In our method, only this method, we show here. It's really he achieved a good result. But transepithelial cross-linking wasn't so effective as this method.
It's now stopped.
Transepithelial, I think, did not make sense. I just didn't because riboflavin would not work. Epithelium, how much you remove is the amount of epithelium you remove is a decision that you need to make. At least for pediatric cases, for children cases, I prefer to remove more because I feel they tend to progress more. If you manage the allergy, so I prefer more removal. For maybe adult cases where stability is likely, then the radial pattern might make sense.
Доктор советует, то есть он как он делает, он у взрослых он удаляет также эпителий, и как вот указано радиальным способом, у детей он удаляет больше эпителия, не радиальным способом, просто
Полностью.
полностью, да.
Эпи-офф.
Да, он рекомендует так. То есть он так делает.
Традиционно. Окей. Thank you.
Yes, my cross-linking terms finished. Finish. Значит, еще один доклад будет посвящен, по нашему мнению, очень интересному клиническому случаю купирования отека роговицы после акселерированного кросслинкинга. Куда? Слайд. Да не, ну все, мышка, все. Нет, так проще. Так, ну, кейс. Пациент, 18 лет, мужчина, в анамнезе без сопутствующих заболеваний, есть аллергия, полинос. Жалобы стандартные для кератоконуса. При обследовании лучший глаз 0,2 зрения с коррекцией до 0,5. Худший глаз 100 зрение. Мы левый глаз готовим сейчас его на пересадку и решили правый глаз провести кросслинкинг. На ОКТ переднего сегмента оценивали степень кератоконуса. Так, анализ плотности проводили на нейтральном микроскопе. Ферментомей. Значит, показатели топографии до процедуры кросслинкинга. То есть видно, что и толщина роговицы, все как бы удовлетворительно, с предела допустимо для процедуры кросслинкинга. Значит, диагноз поставлен правильно обследование. Правый глаз кератоконус 3 стадии, левый глаз 4 стадии. Первый день, после того, как мы провели кросслинкинг, увидели такую картину после первого дня. Хочу сказать, что в течение, сколько мы, уже 10-12 год занимаемся кросслинкингом, в моей практике это первый раз, как бы мы были шокированы, потому что это пациент как бы единственный видящий глаз получается, и резкое ухудшение зрения, отек роговицы, множественные складки диссегментовой мембраны, эпителиальные микрокисты, пузыри. Я немножко на английском задержу. Так, вот показатели переднего сети. Как мы видим, очень сильный отек, порядка 1000 микрон роговица. Такая картина очень неприятная. Ну и мы начали лечение. Дексаметазон 8 раз в день, тобрекс 6 раз в день и увлажняющие капли. В данном случае это гиалуронат. Гиалуронат натрия 0,3%. 6 раз в день. Так, ну, вот на английском опять дублируем. Так, вот 7-й день, никакой динамики от лечения мы не обнаружили. Более того, показатели толщины роговицы еще усилились. И мы решили провести вот данные остроты зрения, отек, такое зрение даже не улучшилось, такая картина. И коррекция лечения по купированию отека. Значит, было принято решение сделать триамцинолон, кинолог наш субтонное пространство. И дополнительно к остальным каплям рекомендовали специфический раствор рипасудил, это ингибитор рокиназы, 0,4%, по одной капле 4 раза в день в течение недели. И уже через неделю показатели начали улучшаться, отек начал спадать, зрение начало прибавляться. И вот мы уже на 30-й день практически показатели уже те же показатели уже улучшились, значительно улучшились. Вот картина на 30-й день, то есть роговица абсолютно чистая, все булы исчезли. Так, вот и сравнительная характеристика уже через 2 месяца. Показатели роговицы через 2 месяца. Острота зрения уже 0,3 с коррекцией 0,5. То есть как бы мы вернулись к тем показателям, которые были до операции, до процедуры кросслинкинга. Через 9 месяцев после операции это показатель роговицы. Так, уже острота зрения, вот именно в данном случае, вот опять комментарий к предыдущему, именно после кросслинкинга, именно у него острота зрения, получается, прибавилась. То есть показатели кератометрии все как бы улучшились. То есть мы добились того, что через 9 месяцев вот такая картина острота зрения. Очки, ладно. Так. Русское язык. Не могу. Русское язык. Заключение. Ряд авторов продемонстрировали, что ингибирование рокиназо-ассоциированной протеин киназы, РОК, стимулирует адгезию, миграцию и пролиферацию эндотелиальных клеток. Увеличивается жизнеспособность, ускоряется заживление ран эндотелия, роговицы инвитро, экс-виво и инвиво моделях на животных. В кератоцитах человека передача сигналов рокиназы является одним из регуляторов, участвующих в окислительных повреждениях и апоптозах клеток роговицы. Дистрофия Фукса. Так. Вот при дистрофии Фукса, по данным этих авторов, капли с ингибитором прокиназы способствовали быстрой резорбции отека роговицы и повышали остроту зрения. Ингибитор прокиназы, который избирательно ингибирует РОК-1 и РОК-2 в дозе 0,4% репасудил, лицензированный в Японии для лечения глаукомы. Это капли Гланатек. В данный момент off-label эти капли рекомендуются в качестве эффективного препарата для адъювантной терапии у пациентов с дистрофией Фукса. Ингибиторы рокиназы могут ускорять заживление роговицы после повреждения эндотелиальных клеток, по данным некоторых исследований, которые доказали, что плотность эндотелиальных клеток и прозрачность роговицы после простого дексаметрорексиса восстанавливались значительно быстрее, если после операции пациента закапывали рипосудил, один из ингибиторов рокиназы. Рибофлавин в сочетании с ультрафиолетом может оказывать окислительное повреждение эндотелия роговицы, отек. А восстановление повреждения эндотелия, вызванного сшиванием роговицы, зависит от дозы. Для быстрой коррекции лечения отека роговицы рекомендовано воздействовать глюкокортикостероидом локально в комбинации с ингибиторами рокиназы. Ингибитор РОК, рипосудил, оказывает защитное действие на эндотелиальной клетке роговицы при кросслинкинге. Результаты исследования предлагают основу для дополнительного изучения точных механизмов и вариантов лечения повреждений эндотелия роговицы в результате окислительного повреждения. Благодарю за внимание. Thank you.
Congratulations. Two questions. First of all, if you have endothelial after the complication, in how was the difference before and after? And the second question, if you, in your opinion, what was most effective for the quick resolution of the edema? A study shows of the rokinase, but maybe it was so fast that maybe the triamcinolone may had played a role, important role in a quick resolution of the corneal edema.
Thank you. Значит, показатели эндотелиальных клеток мы не ставили, да? Здесь это показатели. Эндотелиальные клетки, к сожалению, я сейчас, в принципе, у нас, так скажем так, эндотелиальный микроскоп, оптический эндотелиальный микроскоп не всегда показывает точное количество. У нас конфокального микроскопа нет, поэтому мы не можем сейчас точно судить. Во многих случаях кератоконуса эндотелиальной клетки количество подсчет при оптическом подсчете недостаточно, неправильное. Поэтому мы не стали здесь указывать количество эндотелиальных клеток.
You consider in cases in patients with keratoconus, optic endothelial microscope don't give us so reliable results, and they in that cases they don't do endothelial microscopy, and he do some mistakes in keratoconus.
Unfortunately, we don't have confocal microscopy. Thank you.
Следующий вопрос.
Возможно, кинолог.
Возможно, кинолог стал причиной быстрого улучшения отека.
Ну, понимаете, в чем дело? Да, мы это, честно говоря, мы тоже как бы с коллегами с клиники дискутировали насчет этого вопроса. Дело в том, что при такой ситуации, как бы впервые в практике, мы просто были шокированы. Поэтому все, что мы в голову приходило, все начинали делать.
We will use all methods.
И на самом деле мы вот то, что мы говорили, дексаметазон 6 раз, 8 раз, почти каждый час капали. Я думаю, эффекта не было. И я думаю, может быть, и субтенонный кинолог то же самое возможно. Да. Ну, мы как бы делали все, что возможно, но применяя в каплях дексаметазон в больших количествах, мы могли бы добиться того же эффекта, что и кинолог субтенонной инъекции.
He considers same. Maybe it's due to using of only corticosteroids, but that time it was.
We start in the more time dexamethasone drops, but no effective. Maybe in the как это кинолог модерн, triamcinolone same effect then. And our opinion, rokinase maybe.
During the fire panic and you use anything.
Да, yes. Конечно. Точно. Все. Да. $440. Да, хорошая, достаточная. Именно, вот насчет этого вот, хочу добавить, что, возможно, причиной такого возникновения отека у нас явилось применение именно акселерированного кросслинкинга. Это по нашему мнению. Именно воздействие, именно есть публикация, что при акселерированном кросслинкинге эндотелий больше повреждается. Микрофон.
They use accelerated cross-linking.
Possible. High energy and maybe.
High energy, yes.
Все. Спасибо. Немножко по времени мы уходим, но очень интересная презентация последняя. Номограмма лечения химических ожогов. Я думаю, это будет очень интересно многим практикующим врачам.
My presentation of chemical injuries. Yes. No, the chemical injury given to you. There was one more presentation. Chemical injury, not here. Chemical injury. I had a request to also touch upon a bit about chemical injuries. So this would be a basic presentation because I was told there was a variable audience. So this is broadly about what chemical injury is and what are the options for treatment. So it's probably one of the true ophthalmic emergencies. Often results in significant ocular morbidity, generally affects children and young adults. And alkali injuries are more common and definitely to the eye can be more fatal than acids. The epidemiology, at least what we find, is about 2/3 tend to be males. Workplace in about 2/3 of patients, 2/3 by alkali, 2/3 are minor, which is grade 1 and 2. In India, firecracker injuries, lime, and accidental injury in chemical industry workers is also quite common. Now, the severity of the disease is related to the chemical composition, the pH, the volume, the concentration, the duration of contact, the degree of penetration of the chemical, and the mechanism of injury usually is different between acids and alkali. So if you have two types, you have basically the alkali and the acid, and both work slightly differently. Now you have a multiple range of alkali substances. You have ammonium hydroxides, sodium hydroxides, potassium hydroxides, magnesium and calcium. And you can get it across. Remember, these are quite very highly alkaline. pH, normal pH is 7, 7.2. They go up to almost 12, 12.5. So fertilizers, drain cleaners, fireworks, cement, plaster, whitewash, quite common. And all of them have actually, at least the ammonium and the sodium, have rapid penetration. Potassium hydroxide is corrosive and dissolves in water. The magnesium from fireworks has both chemical and thermal problems. And the calcium hydroxides is basically poor penetration and then tends to have a retained particulate matter, which tends to be a slow diffusion into the ocular surface. And you can get them in everyday life. You can get them in your house, you can get them outside. We do get, on all of these are actually available on a fairly common basis. Now acid has a different subset. You can get pH from 1 to almost about 3, and all of them are used in some part of your everyday life. Battery acid, industry cleaners, fruit and fruit preservatives. You have vinegar, which is used in cooking. You can get it in even chrome plating. And the effects, all of them tend to have reasonably good penetration, at least on the ocular surface, but that seems to be a coagulation that limits the effect of this. And commonly vinegar and battery are common access that you see them in everyday life. Now there is a chemical process to it. The alkali basically dissociates its hydroxyl molecules and then goes into the cornea. The hydroxyl ion basically saponifizes the cell membrane by fatty acids, and this causes the release of the proteolytic enzymes. This results in deeper penetration in the cornea and the anterior segment. in acid, the hydrogen molecules have denaturation, so that causes precipitation, and this basically prevents a barrier and prevents deeper penetration compared to alkali. There is basically the pathophysiology. How does it actually occur? You get necrosis of the conjunctival and corneal epithelium, you get disruption of the occlusion and the occlusion of the limbal vasculature that causes loss of limbal stem cells. This leads to conjunctivalization and vascularization, and then you have persistent epithelial defect with corneal ulcers. Now the healing basically is multiple options. One is of course the centripetal movement from the peripheral cornea, limbus and conjunctiva responsible for normal and post-traumatic replacement of the corneal epithelium. There is of course only a partial trans-differentiation post-injury, so that's the reason you get conjunctival epithelium. The limbal stem cells are of course the preferred method to restore the functional competence of the corneal epithelial injury, but usually the rate of replication of limbal stem cells is less than conjunctival epithelium. There is a damage of the collagen also. That's why you have basically keratite functions. You have phagocytosis of the collagen fibrils, that is synthesis and secretion of the collagen glycosaminal glycan ground substance, and you have collagen inhibitors. This all is modulated at the cellular level by cytokines. So there is a lot of basal level chemistry that is taking place in the corneal stroma. Now we do know there are four phases: immediate, acute, early repair and late. Whereas basically immediate is at 0 day, acute is 0 to 7 days, early repair is 7 to 21, and late repair is about after 21. Now in the immediate stage where you have mild burns, the epithelium is destroyed, that is immediate limbal ischemia due to damage of blood vessels. There can be a rise of intraocular pressure. The initial peak is due to compression of the globe because of dehydration and longitudinal shortening of the collagen fibrils. The second peak is due to impedance of the aqueous humor outflow. Now in the early repair stage, which is 1 to 3 weeks, this is basically replacement of the destroyed cells in the extracellular matrix. So in grade 1 you have epithelium regeneration, in corneal neovascularization there tends to be a bit of clearing of the stroma and synthesis of the glycosaminoglycans. In grade 3 to 4 the regeneration may not start, and the stroma tends to remain hazy. The endothelium, if it's very severe, is replaced by a retrocorneal membrane. So in stage 3 to 4 corneal ulceration tends to occur. Stromal ulceration is due to the action of the digestive enzymes such as collagenases and MMP, the metalloproteinases. In the late stage, this is basically completion of healing. You have inflammation, collagen synthesis, and collagenase activity, which will be enhanced. So chance of perforation and infection tends to be in the late stage. Of course, quite common clinical features that are symptoms: pain, lacrimation, photophobia, blepharospasm, and decreased vision. Signs include eye edema, chemosis, and of course corneal aberrations. Now these are the broad effects of ocular surface bone. In lids you can end up in the early stage edema and dermatitis ulcers. In late stage you can have ectropion or entropion. In conjunctiva the initial chemosis can end up with symblepharon or pseudopterygium. In cornea the edema and the corneal ulcers can end up with perforation, vascular opacities and xerosis. For the uvea, the anterior uveitis can become a chronic iridocyclitis, and the IOP can be increased both in the acute and the chronic stage. Now you need to look at the examination. Eyelid, you need to check basically for any lid edema, any distortion of the lids, especially if you have any inturned or outturned eyelashes, especially and opposition to the globe. The ocular surface epithelium, an important part, is used with fluorescein staining. You look at both the lower palpebral, inferior bulbar is easily informed, but you also need to evert the lid and look for any chemicals trapped in the fornix and anything at the tarsal plate. The limbal examination extremely important because you can have limbal damage and loss of epithelial cells. So the limbal ischemia, as in this picture, shows areas of pale limbus, limbal edema, necrotic tissue, hemorrhages and stagnant blood vessels, which basically show poor blood flow. The initial management is saline irrigation. You do a conjunctival sac is thoroughly washed to neutralize the pH, and basically irrigation in the initial stage improves the prognosis for the injury. You can use normal saline, regional lactate, or any clean fluid or water. Chemical particles embedded in the tarsal conjunctiva can release slowly, so this can be important to remove it. 90 minutes shows irrigation shows about 1.5 unit reduction of elevated pH. So irrigation of at least 30 minutes, checking the pH as a regular part, that is important. The double eversion of the eyelid and another important part, and debridement can be done in the primary visit itself. Make sure that you measure the pH, the slit lamp examination, fluorescein staining, IOP, and grading of injury. Now, most times if it's a work related injury, you need to of course record it. Sometimes we also need to check if there's any initial first aid given. Usually just a 10-minute or 5-minute wash would not help, so it's important that what therapy was given. A lot of them tend to use some local steroid antibiotics. A small touch upon the different classifications. They have basically 3, and I would recommend that we work with the DUAS classification. Even though Ropo-Hall was an older classification, no longer used, wherein it only looked at the epithelial defect. The grade 2 looked at the haze as well as the epithelial defect. The grade 3 looked at the total loss of epithelium, stromal haze, and about limbal ischemia, which is basically guarded visual prognosis. And grade 4, you have an opaque cornea, more than 50% limbus with poor prognosis. Now, in the DUA classification, the limbal involvement is in clock hours and percentage of conjunctival involvement is there. In a randomized controlled trial for ocular burns, the DUA classification was superior to the Ropo-Hall in predicting outcome of severe burns. However, both classifications are commonly involved. But this is important because remember that chemical injury is never a one-time injury. You need to follow up these patients long term. It's a very complicated, slightly busy slide, but remember that DUA's classification has 6 grades, from prognosis from very good to very poor, depending on the amount of limbal ischemia, conjunctival involvement, and they basically gives an analog scale based on this. So if you're really interested, I can share the article. So this is something like where you have a grade 1 involvement, no limbal involvement, fluorescein staining gives a diffuse view of the cornea. This is grade 2, which is basically 3 of 30%. You have about 3.5 hour clock hours of limbal involvement with 30% conjunctival involvement. So both limbus and conjunctiva are important for your prognosis. So this has to be done in the acute stage. Grade 3, you have 5 clock hours of limbus involvement with lot of conjunctival involvement, and this is basically grade 3. Grade 4 is ocular surface. You have plenty of limbal involvement, 50% of conjunctival involvement. In this patient, there is an autologous limbus transplant following with a PK about a year back. Now in grade 5 is where the sequelae are more likely, where you have extensive involvement of the ocular surface, you have involvement of the conjunctiva, and with limbal stem deficiency you tend to have extensive conjunctivalization. This is a grade 5. So remember, it's in evolution. A grade 6, you have almost the entire ocular surface, that's the limbus and the conjunctiva, showing severe chemical burns. Now the aim is basically to enhance the recovery, control inflammation, augment the collagen synthesis, and minimize the collagen breakdown. The grade 1 and 2 are usually managed well with medical treatment alone, but you will require admission for grade 3 and 4. Now steroids are the mainstay for reduction of tissue injury. So you need to use basically a fair amount in the first 7 to 10 days, which is when you would have the best response to steroids. Tear substitutes, important. You need to probably use them long term. Eye ointments, preferably at bedtime, very important for persistent keratopathy and recurrent epithelial erosions. You can use platelet-rich plasma eye drops if you can prepare it in your lab. Citric acid has basically a way of improving the preventing the collagenolisis. It aims to prevent the second wave of phagocytes, usually about 7 days of injury. And you can get them as eye drops or even as tablets. Tetracyclines along with acetylcysteine have a role to play. I'm actually a big believer of both systemic and topical tetracycline. And you can use acetylcysteine. It basically prevents anti-collagenase activity. The IOP to be monitored, and you can give oral acetazolamide. Symblepharon has to be prevented in the acute stage, and this can be prevented while using either a sterile grass rod, a damp cotton bud. You can even put in a symblepharon ring. So basically the nomogram would be grade 1, topical antibiotic, topical steroids, preservative free artificial tears, and you can use a cycloplegic. For grade 2, topical antibiotic, more steroids, long acting cycloplegic like atropine, sodium ascorbate drops, which are available at least in India. I'm not sure about Uzbekistan. Oral vitamin C eye drops, tablets twice daily for 2 to 3 weeks. You can also give doxycycline. You can give preservative free, debridement of the necrotic epithelium, and application of tissue adhesive if there is perforation as needed. For grade 3, you add in what we have discussed. For grade 2, you can consider an amniotic membrane transplant in the first week of injury. This is basically to cover the palpable conjunctiva by suturing to the lids. In grade 4, early surgery is usually necessary. You can have significant necrosis. So tenoplasty along with amniotic membrane transplant in the acute stage becomes an important part of management. For surgical management, anything beyond grade 3 to 6 in Dua's classification to promote revascularization of the limbus and restore the limbal stem cells, and of course re-establish the phonesis. So in amniotic membrane, basically quite straightforward. If you have access locally, or you can get it from the gynec department, it's basically a basement membrane. It has multiple growth factors. If you can use it fresh, it's probably best. It provides a substrate both for the epithelium to grow, also provides a collagen basically to support. And this I'll skip. Aim is to restore the conjunctival surface, suppress fibrosis and scarring. You can use cryopreserve, which is available, or you can use fresh, depends on what you would like to use. Remember that you need to use the basement membrane oriented downwards. That is, the amniotic membrane basically acts like an onlay patch graft. So when used with the basement oriented upwards, it acts as an inway graft which promotes epithelialization. So in chemical injury, you probably need to use it as an inlay graft. Irrespective of the transplantation technique, amniotic membrane facilitates basically reepithelialization and maybe a partial limbal cell function. So how do you use it? Basically you lay it on the conjunctival surface. You can use a running suture along the limbus. You can use fibrin glue into the phonesis. So it's important that you extend the amniotic membrane up to the phonesis so that the limbus and the phonesis are covered at all times. Now tenoplasty is basically to remove the dead tissue, the necrotic tissue, can be done in the first 2 to 3 weeks. The tenons then from the healthy part is augmented and sutured along with the AMT. The aim is to provide the ischemic limbus with healthy vascular connective tissue, promotes reperfusion through the tenon's limbal vasculature, and helps in wound healing and tissue repair. Now this is basically what you're bringing the conjunctiva forward. You suture it to the limbus so that the blood vessels kind of start vascularizing the dead part of the cornea. The limbal stem cell transplant usually is not done in the acute stage. It is the deficiency is basically of long term. So usually in about 3 to 4 months you will see this conjunctival growth. You may see partial or complete. And the sequelae include conjunctivalization, persistent epithelial defect. You can get ulcers, melting, and perforation. Like in this patient, there is significant vascularization, which is conjunctivalization of the ocular surface. Now you can use autologous, that is from the unaffected eye, or you can use allogenic from another person, which is usually mostly bilateral from cadavers, also needs long-term immunosuppression. Now the surgical techniques, these are the older techniques which you basically conjunctival limbal autografting, no longer usually done. The other was cultivated limbal epithelial transplantation, but you need a lab for that. That is also not commonly used. Now what is usually preferred now is something called SLET, which is simple limbal epithelial transplant. You can use autologous, that is from the fellow eye, or allogenic, basically from the donor cornea. If you do a dissection preserved in MK medium or in Optisol, you can use that. They can be used for dry eye, Steven Johnson's, MMP, even ocular allergy. Now, how does it done? Basically, use the biopsy from the donor eye. You remove all the pannus. You do an amniotic membrane usually in the first stage, followed by using the slit in the second stage. You make multiple biopsies, place it on the ocular surface, and then put a bandage contact lens. Now, this is how it looks. You can make out small bits of tissue on the ocular surface. That is multi-directional growth of the epithelial cells and complete, usually surface epithelialization in about 14 days. The human amniotic membrane acts like a substrate for the secure attachment, and we find that in about 3 months, if the prognosis is good, usually the cornea will clear. Keratoplasty can be preferred or combined with limbal stem cell transplantation. For large perforations, something like this, you will require definitely a keratoplasty along with limbal stem cell transplantation. This is a 1-month autologous slit where you have still epithelial defect combined with PK. This is the last part about keratoprosthesis, usually indicated in multiple failed keratoplasties, especially the type 1. I would not go into the details, but this is how it looks. You really don't need limbus for this, and most of these patients, if managed well with the contact lens with regular follow-ups, actually do quite well. This is the OOKP. We did publish this during the initial studies in Singapore, but it is a lot more bigger procedure, requires a lot more follow-up, usually not recommended unless you have a multi-dimensional team including dentists for this. I'll skip this. This is basically references. If you're interested, I can share the Harminder Dua article. And these are multiple articles that we have actually used for this. Thank you for your attention. I know it's been a long day.
Thank you, Dr. Anand, thank you. Это был последний наш доклад. Я хочу сказать, это у нас как бы это все постараемся выложить в сеть, в записи. Этот последний доклад очень быстро был прочитан, но он как бы познавательный, то есть как бы это для практикующего врача, то есть начальная часть. Потом уже даже такие тяжелые пациенты, у них есть шанс на реабилитацию, получается. Я благодарю всех участников сегодняшнего семинара, вебинара. Спасибо вам большое, наших гостей, доктор Леонард Аркетти, доктор Ананд. Thank you very much, что уделили остальным всем моим друзьям, коллегам, чтобы хватило терпения, что дослушать это. Роговица очень тяжелая вещь. Надеюсь увидеться на следующих наших роговичных клубах. Спасибо. Спасибо. Фото последнее. Общее фото один сделаем.
Фото мы сделаем у главного входа.
Почему это актуально?